Hi everyone, welcome back. Today we're going to be going over our second session of our high yield hump days. We're going to be going over endocrinology, GI, and neuro, and we're going to be going over 20 questions of each of those topics just to give you guys a little bit more taste into what you might see on step one. And these might be some recaps of some of the questions we already did in our longer sessions, but these will probably be a much shorter, but also much more refined what's high yield that you'll see on step one. All right, let's get started. Starting with question number one. We have a 32-year-old woman that presents with weight loss, palpitations, and heat intolerance for 3 months. All right, so if we're thinking of, obviously this is our endo at the beginning, but if we're thinking of our endo, what kinds of things will match weight loss, palpitations, heat intolerance? In theory, we do have our hyperthyroidism, which likely is what's going to be going on in this route. What's causing it, we don't know. We could have pheochromocytomas as a possible remote option, right? Because if we're building our differential for step one, step two, it's good to have that differential. Make sure you know what you're considering as you go along in the question and see, okay, what's ruling it in, what's ruling it out. And then anxiety, potentially, if they just have really bad anxiety, they might not be eating well, they might have palpitations, they may just be anxious and sweating a lot. But also hyperthyroidism can be masked as anxiety oftentimes. So obviously we're going to think hyperthyroidism is our first guess, and what's causing it we don't know, and then we can consider the other ones as we keep going. She recently had a URI. Physical exam shows a mildly enlarged, tender thyroid gland. Labs show elevated free T4, suppressed TSH, and low radioactive iodine uptake. Which of the following is the most likely diagnosis? So if we're breaking down what we have, a recent URI predisposes you to a very specific condition that can cause hyperthyroidism. But this basically is confirming that we have hyperthyroidism, right? Because we have elevated free T4, suppressed TSH, which means this isn't some sort of mechanism driven by the pituitary gland secreting too much TSH or the hypothalamus secreting too much TRH, right? This is mainly some sort of intrathyroid issue. And then we have low radioactive iodine uptake. So if we have elevated T4 and low TSH, this is coming from inside the thyroid. The call is coming from inside the house, right? But then if we also consider low radioactive iodine uptake, then that means our thyroid is not actually producing T4. We're just dumping T4. There's different conditions in which we may just release T4 without actually producing it. And those are things like destruction of our gland. If we have autoimmune destruction of our gland, if we have some sort of inflammatory destruction of our gland, or things that are causing inflammation in general, we're going to release thyroid hormone without actually producing it. So whenever we have a low radioactive iodine uptake, that means that we're not taking it into the thyroid. We're not taking up iodine to make thyroid hormone. We're just releasing whatever thyroid hormone we did create. So if we're combining the fact that this patient had a recent URI, now she has a tender thyroid, this is going to match subacute thyroiditis, usually also called de Quervain's thyroiditis, possibly granulomatous thyroiditis. There's different names, subacute granulomatous. But long story short, this is a painful thyroid that is going to release thyroid hormone because this inflammation from after a recent URI, we're going to have inflammation that's going to release thyroid hormone from our gland without us actually producing any new thyroid hormone. It's usually self-limited. Just give them some NSAIDs. If you need to give them a beta blocker, you don't really typically need to because these are usually self-limited, but give them things for the anti-inflammatory side and you should be good to go. All right. If it's some sort of toxic multinodular goiter or some sort of adenoma, then we would have increased synthesis. So you would have increased radioactive uptake, right? We wouldn't have decreased because we'd be overproducing in this sense. In our question stem, we're underproducing. We're just dumping what we do have available. Hashimoto's is hypothyroidism. So that would be the complete opposite end of the spectrum. We'd be cold. We'd have hair that's falling off, right? That's Hashimoto's. Graves' disease is hyperthyroidism, right? We have the antibodies that activate our gland too much. But in this case, we would be creating too much again. Those antibodies that are going to be activating the TSH receptors normally on our thyroid, they're going to be producing too much thyroid hormone. So we'd have increased T4. Right? And then Hashimoto's would be decreased T4. There might be a transient period at the beginning of Hashimoto's where you have a little high T4, but long term you'd have decreased. And then some sort of thyroid adenoma, again, you'd probably have some sort of increased radioactive iodine uptake as well. All right. So this one's going to be subacute granulomatous or subacute, which is also called de Quervain's thyroiditis. All right. And then I won't take a second usually after each question, but I want to make sure, how did this first question go? Did it look good on everyone's screen? Explanation go well, that kind of thing? Hopefully everyone can hear me. Okay, okay. Cool. Oh yes, I can open up my chat box too, just in case. I didn't. Thank you, Armand. I did not realize you said that earlier. Okay, moving on to question number 2. We have a 45-year-old man with hypertension and muscle weakness is found to have hypokalemia and metabolic alkalosis. So, in terms of hypokalemia, metabolic alkalosis, a lot of things that can cause it, we could have some diuretic issues, right? If patients have hypertension and now they have muscle weakness, they could have some sort of metabolic alkalosis from taking a diuretic. But we could also have some sort of adrenal issue, right? Because this is our endocrine section. We're not going to assume on the real test, you can't just say, oh, I know this is the endocrine section, so I'm going to say it has to be some sort of adrenal issue. You have to be considering what our differential is. Could be some sort of issue with a diuretic, could be adrenal, could be a couple different things, right? But for the most part, we know this is our endocrine section, so we're probably going to have some sort of endocrine adrenal answer. But let's keep going. Our plasma renin activity is suppressed, so that means our renin activity is low. We likely might have low aldosterone, but let's see. And aldosterone levels are elevated. I take that back, right? So our renin is down. Renin is typically going to release or cause us to release aldosterone, but we still have aldosterone levels that are high, even though our renin is down. CT scan reveals an adrenal mass. Well, that's probably what's releasing all our aldosterone, right? So whenever we have a lot of aldosterone, what is aldosterone causing us to exchange? It's going to make us high blood pressure because we're trying to reabsorb sodium in order to trade out potassium. And with the reabsorption of sodium, we're going to take back some water as well. And that's why our blood pressure is going to go up. And then you may also notice that they have this pseudo hyponatremia potentially because they're reabsorbing so much water that it looks like they have too little sodium. But for the most part, every time we have high aldosterone levels, we're going to have super high blood pressure. And then we're also going to have very low potassium, which is going to match what this patient has, right? The hypertension, because we're reabsorbing so much of that sodium, so much of that water, the muscle weakness, hypokalemia, and even the metabolic alkalosis are all going to be caused because we're dropping so much of that potassium that we're going to result in an issue, a shift with our hydrogen, our acid production as well, right? So what do we consider this? Well, if they have a CT scan that shows an adrenal mass, that means it's an adrenal cause to what's happening. And that by definition is going to be primary hyperaldosteronism. That means we probably have some sort of adenoma that's creating too much aldosterone, right? And in this case, primary means it's coming directly from the gland that is related. Typically when we think secondary, that means some sort of other gland or some sort of primary other position is causing it. So if we're thinking of primary hyperparathyroidism, secondary, tertiary, right? Primary hyperparathyroidism is that our parathyroid gland is producing too much of the hormone. Secondary, even tertiary, is because something else is causing too much of either our hormone to be released or potentially us to not be able to respond to whatever calcium we do have. But every time we think of primary versus secondary, is the gland itself messed up or is something else causing the gland to react, right? So in this case, primary, it means that we're secreting too much of that aldosterone. Secondary, that would be something else like we'd have the renin elevated, right? Some sort of tumor that's secreting a lot of renin, and then that's why we're secreting a lot of aldosterone. Cushing syndrome, that would be cortisol driven. It's not just aldosterone. So this patient might have really bad glucose, right? They'd be like diabetic all of a sudden, or some other type of symptom that would match some sort of steroid, right? Congenital adrenal hyperplasia, you would see that probably a little earlier, like in childhood, right? And then you'd probably also see some sort of steroid mixed in, not just the aldosterone pattern. And then adrenal cortical carcinoma, another thing that would have mixed cortical secretion usually. You'd probably have some sort of androgen mixed in or cortisol, not just the aldosterone. All right. Cool. And this one is also called Conn syndrome in case. Typically, they don't really call things by name as much anymore. You're not really going to see like Friedrich Waterhouse syndrome when you have like adrenal necrosis but they may just call it adrenal necrosis on exam, that kind of thing. All right, let's move on to question 3. We have a 6-year-old boy presents with polyuria, polydipsia, and weight loss. At baseline, whenever we think polyuria, polydipsia, weight loss, probably some sort of diabetes. Whether it's insipidus or mellitus, usually that's going to point towards mellitus if they're losing weight, but probably some sort of diabetes. Labs show a glucose of 450. So glucose through the roof, we're pointing towards mellitus now. Whether it's type 1 or type 2, we'll figure out. And then a positive serum anti-glutamic acid decarboxylase antibody. So why is this important now? If we have this antibody, where is this enzyme typically going to be found, right? Is this going to be typically found in our beta cells, right? Because if we need this enzyme in our beta cells, and suddenly we have these antibodies that are going to be circulating and killing off our beta cells in our pancreas, we're not going to be able to produce any of our insulin. So if we're killing off beta cells, we're not going to be able to make insulin. So we're going to have no insulin. And this is considered an autoimmune destruction. So this we would call type 1 diabetes. Versus type 2, it would be some sort of insensitivity to insulin, right? And then what are we going to see in terms of our answer choices? What's going to match? This is going to be an autoimmune destruction of our beta cells, like I was saying earlier. Since we have an enzyme that's typically going to be found in our beta cells, that's how we're going to be producing a lot of insulin in the first place, or potentially even glucagon, depending on which type of enzymes we're going after in the diabetes mechanism, then this is going to cause destruction to our beta cells, all right? But in this case, whenever we think of a high glucose, someone this young, it's always going to be type 1. Typically, I mean, things are happening nowadays, but typically it's not going to be type 2 this young of an age. And then from there, just trying to figure out what does type 1 match with. So even if you don't remember, what does anti-glutamic acid have to do with anything? I don't remember, but you have high glucose, very young child. It's most likely 99% of the time going to be type 1 diabetes. Which one of these answer choices matches it? It's going to be the autoimmune destruction. All right. All right. Let's keep going. Question number 4. We have a 28-year-old woman that presents with galactorrhea and amenorrhea. MRI reveals a pituitary mass. Serum prolactin is markedly elevated. Which of the following mechanisms best explains her amenorrhea? So whenever we're thinking of galactorrhea, amenorrhea, and then you have high prolactin, there's 2 different things you can consider for what could be causing it. A prolactinoma could be causing it, or we could also have decreased secretion of LH-FSH if we just have some sort of mass that's blocking production in our pituitary gland. So what's interesting is that when we're trying to make prolactin, the pituitary gland is sitting there, and it's sitting with negative feedback in terms of making prolactin, and this negative feedback is controlled by dopamine. And the hypothalamus is always ready to tell the pituitary gland, hey, you should make some prolactin. The pituitary is just told, hey, no, there's dopamine, don't make it. As soon as that dopamine is gone, so let's say we have a tumor that's crushing the dopamine that could be secreted, suddenly now we just have a wide open prolactin and we can start making prolactin. So there's 2 different ways we could have high prolactin. Either a prolactinoma that will actually release its own prolactin, or something like a craniopharyngioma type thing that might be crushing the pituitary stalk. It could also cause an increase in prolactin just because we have blockage of that dopamine, all right? But if we're considering which one of these reasons might be causing her amenorrhea, well, amenorrhea is likely more of our FSH-LH, but why would someone have an issue with FSH-LH and prolactin being increased at the same time? This is likely to do with the fact that we don't have any GnRH secretion, all right? Because if this patient has a prolactinoma, that's going to drastically increase. Actually, let me leave that there. A prolactinoma is going to drastically increase how much prolactin is released. and that will result in galactorrhea. The original mechanism of crushing the stalk likely won't result in galactorrhea, but a true prolactinoma will result in galactorrhea. Nope, I can't spell today. There we go. Now that we have galactorrhea, we have a lot of prolactin. Prolactin is going to act as a negative feedback mechanism to block FSH and LH production. And that's because it's also blocking GnRH secretion, I should say. It's blocking it from the top. So if we're not producing any GnRH, right, gonadotropin releasing hormone, then we're not going to be able to release FSH, LH from there. And then in that case, we're going to have amenorrhea. This is going to result in amenorrhea. All right, so in this case, decreased GnRH secretion because of the prolactinoma is going to result in amenorrhea. All right. And if it was just FSH or LH, that wouldn't really make too much sense because both of them are in the pituitary gland, right? Both of them are released from the pituitary gland. We shouldn't have just one or the other if we have some sort of pituitary gland issue. It should be both. And sure, that could be fine, but it probably wouldn't produce too much prolactin if it were just that pituitary stalk tumor. It should be a true prolactinoma that'll secrete too much prolactin. All right. All right. Let's move on to question 5. We have a newborn that presents with ambiguous genitalia and salt wasting crisis. Labs show hyponatremia, hyperkalemia, hypotension, and elevated 17-hydroxyprogesterone. Which enzyme deficiency, is most likely present? All right, so whenever we see a patient that has ambiguous genitalia, but then we also see all of these hyponatremia, hyperkalemia, all these kinds of things, it's likely that this patient has the chromosomes for a female, but there's too much androgen production. Because in a lot of our congenital adrenal issues, usually we are shunting away from cortisol and aldosterone and shunting to androgens. So let's kind of start up with our whole mechanism, right? We have cholesterol. Cholesterol as a whole is going to be shunted down to 3 different things, right? And this is aldosterone, cortisol, and androgens. All right. In a lot of these different mechanisms, you might have an issue making anything on this side, so you'll have a ton of aldosterone, but you can't make cortisol or androgens. And in those cases, you're going to have super high blood pressure. You'll have the hypokalemia, kind of like we talked about a couple questions ago. This one, we don't have that case, right? We have hyponatremia and hyperkalemia. So that means we're not making cortisol, right? Because we talked about how cortisol is supposed to reabsorb sodium and release potassium into the urine. In this case, we have the opposite. We're not reabsorbing any sodium at all. We're going to have hypotension. So that means we have some sort of mechanism that's not letting us create aldosterone. Well, we also likely have some sort of issue making cortisol in this case, because cortisol should be able to produce reduce some of the hypotensive effects. So which one of these mechanisms is going to block potentially aldosterone and final cortisol production and only allow androgen production? This is going to be 21 hydroxylase. 21 alpha hydroxylase is sometimes what they'll call it as well. If we were thinking of some of these other answer choices, 11 beta is going to result in hypertension because you're still able to make it to a molecule that resembles aldosterone sufficiently. It's not true aldosterone, but it resembles it enough. And then if we're thinking of something like 17 alpha hydroxylase, that's going to be low androgens. This patient has too many androgens. And typically how we'll classify this is going to be a 46XX female that now has way too many androgens, and that'll result in the ambiguous genitalia. The reason why this is typically a female at birth is that if this were a male, they would actually result in precocious puberty. So it'd be like a 5 or 6 year old, right, coming in already with pubic hair, potentially growing testes, right? So in these cases, it'd be precocious puberty. And if you're trying to remember what age would be the normal onset of puberty for males and females, Females are going to be 8. Anything before that is precocious. Males are going to be 9. Anything before that is precocious. All right. So in this case, 21 alpha hydroxylase is the answer. Aromatase is going to be an issue in terms of making estrogen, right? Aromatase is how we take androgens and convert it into estrogens. And then 5-alpha reductase. So let me put this here. This is estrogens. And then 5-alpha reductase is how we make DHT, right? So this will take androgens and make dihydrotestosterone, which is that final form of testosterone. That's how we'll differentiate and make our external organs, right? So for males who can't make DHT, if they have the 5-alpha reductase deficiency, they won't have any issues in terms of making normal testosterone. They just can't make a full-blown dihydrotestosterone, all right? Okay, let's move on to number 6. We have a 50-year-old man presents with central obesity, moon facies, and purple abdominal striae. He has high cortisol levels that do not suppress with low dexamethasone, but suppress with high dexamethasone. What is the most likely diagnosis? So whenever we think of these issues with Cushing, right, and we have, someone has purple abdominal striae, moon face, central obesity, they have high cortisol levels. It's a matter of trying to figure out where this tumor might be coming from, where it could be causing this extra ACTH or cortisol to be released, because typically these are going to be ACTH secreting tumors, right? And then ACTH will cause us to have all of this extra cortisol released from there, right? So if we measure our ACTH and we have a low ACTH tumor, that's probably going to be an adrenal source because it needs to just make the cortisol on its own. If we have a high ACTH, then we have to figure out if it's a pituitary issue. So let me kind of break this down. Low is typically adrenal because that means it has to make it on its own. It doesn't have something commanding it to say, hey, let's make a lot of cortisol. If it's a high ACTH issue, this is where we have to figure out, is it pituitary? Is it the pituitary gland that has an adenoma that's secreting? Or is it ectopic? Right? Some of you might remember some of these squamous versus small cell carcinomas, and you're trying to remember, which one causes the PTH-related peptide, which one causes the ACTH, right? Small cell is going to cause ACTH secretion, right? So in this case, we could have an ACTH ectopic tumor, and that one will not respond to any of our dexamethasone release, all right? So in this case, low dexamethasone will be the adrenal gland. High dexamethasone, like when it responds, I should say. Response with low, response with high dex. And finally, ectopic just does not care. All right? It does not care what's going on in the rest of the body. It will not respond. It's just too busy making too much ACTH. All right, it's really not going to give, any sentiment to what's going on in the rest of the body. So if we do have response with high dexamethasone, then in this case, this is Cushing's disease, the true Cushing's disease, in which case we have some sort of tumor that's producing too much ACTH in the pituitary gland. All right. So Cushing syndrome is just when we have too much of cortisol in the body. The true Cushing disease is when it's a pituitary tumor. All right, that's how we'll differentiate this. And then again, ectopic ACTH, we're thinking of some sort of pulmonary tumor. Adrenal adenoma, that would respond to low dex. Iatrogenic steroid use, technically that could be resulting in some of this, but we should see that the patient doesn't have high dexamethasone once they've been in the hospital for a while, and they probably would go into crisis, adrenal crisis. And then adrenal carcinoma, that's probably going to make more than just cortisol. Remember we were talking about that earlier. We'd have a mix of the different hormones, whether it's aldosterone, whether it's testosterone, androgens, right? So that's how you can kind of differentiate these. All right, let's move on to 7. We have a 60-year-old woman that presents with fatigue and cold intolerance. Labs show elevated TSH and low free T4. Anti-thyroid peroxidase antibodies are positive. Which of the following best describes this pathology? So now we have a patient that's coming in and they have signs of hypothyroidism, right? Fatigue, cold intolerance. If we're going to go by hypothyroidism, versus hyperthyroidism. Let's kind of list out some of these symptoms that we would be expecting. Hypothyroidism, yeah, we'll have the fatigue. You'll be cold. You'll have diarrhea. You'll have dry skin. Hair falling out. Slow reflexes. Right, and then if we're thinking hyperthyroid, it's basically the exact opposite of all of these, right? Katy Perry's hot and cold, yes and no, in and out, right? So it's the exact opposite. So we're going to be, I mean, in theory, fatigue actually can come from both, just because you'll be doing too much and your heart's going too fast in hyperthyroid. So I'll just give it a little bit of fatigue. You'll be doing a lot. But aside from that, you're going to be hot. Sorry, I mixed up the diarrhea. This is the wrong way. That's constipation on that side. Constipation is on this side. My apologies. Now we're going to have diarrhea on this side. You're going to have probably this like wet skin just because you're sweating all the time, sweating profusely. You're going to have this like thicker hair, probably. And it's going to be wet too. And then you're going to have fast reflexes. So that's how you can kind of break down these two different sides, what's going to have which symptom, that kind of thing. So if we're trying to think about what our best answer is, well, we have an issue with hypothyroidism and an antibody that's likely causing this hypothyroidism. And we have high TSH. So it's not that this is some pituitary issue, right? We don't have a pituitary insufficiency. We have a true thyroid insufficiency. Which one of these is going to match which one of our major conditions, right? If we're thinking Graves' disease is going to be a antibody that's causing hyperthyroidism. It's causing activation. That's not what we have here. This is going to match something more like Hashimoto's. Hashimoto's thyroiditis is what we have. And which one of these answer choices is going to match Hashimoto thyroiditis? This is going to be lymphocytic infiltration of the germinal centers. What's happening is that we have destruction of the gland by T cells and all these different lymphocytes, and they're going to cause permanent damage to our thyroid. Typically, Hashimoto's disease is just really treatable. For the most part, you just wait for the destruction to happen, and then you just give them lifelong T4. So you'll give them levothyroxine or Synthroid, as they'll call it, and you just give it to them lifelong. There's really no effects. The only times you'll have to make sure you watch out for it is if the patient becomes pregnant, or if they're taking birth control pills. Everyone's probably wondering why. If you're pregnant, estrogen is going to cause the increased release of binding globulins, including thyroid binding globulins. And our body reacts based off of the free levels of all these things. Free calcium is what we respond to. Free thyroid hormone is what we respond to. If there's an increase in something that's supposed to bind the thyroid hormone, then we're going to have less free thyroid hormone, and our body's going to say, oops, we have hypothyroidism now, let's do all these constipation and all these other things, right? So we may need to give them increased levothyroxine in those kinds of situations, all right? But for the most part, it's a pretty tame condition that as long as you're treating it properly, the patient won't have long-term effects, all right? Let's move on to number 8. We have a 40-year-old woman that presents with episodic headache, sweating, and palpitations. Plasma metanephrines are elevated. Which of the following cell types is responsible? So this patient has a pretty classic triad of symptoms that we would expect, especially when someone has an increase in the terms of metanephrines, right? So if you have too many metanephrines, you're going to have the hypertension. Let me kind of list these out. You have hypertension, tachycardia. They're sweating, sure, but these are the classic symptoms that we would expect in someone who may have a pheo, right? A pheochromocytoma. Pheochromocytoma, that's going to be a tumor that's releasing a lot of different catecholamines and metanephrines, that kind of thing, right? Where it's going to release epinephrine, norepinephrine. That's where you're getting all this sweating, hypertension, that kind of thing. And then typically what we look for is which cell is going to produce it. I mean, technically a pheochromocytoma is a neural crest cell derivative. So if you're trying to remember your embryology, like, oh, you know, which one of these areas does it come from? Is it, you know, ectoderm, mesoderm, you know, and all these other things? This is going to be neural crest cell. And on top of that, when we're thinking of which cell is going to cause it, just kind of think of the name chromo. I like to try to remember that. Pheochromocytoma, it's going to be chromaffin cells. Chromaffin cells are going to be the one that's producing all of these excess in epinephrine, norepinephrine, and that's what's going to cause all these issues. All right. When we're thinking of the different areas of the adrenal gland and what they would be releasing or that kind of thing, like the zona glomerulosa, that's aldosterone. All right. The zona fasciculata, that's going to be cortisol. And then you're probably thinking, oh, why not reticularis? That's going to be the testosterone or androgens, I'll say. And then parafollicular C cells, that's going to be something like calcitonin. That's how we'll tell if we have like something like a medullary thyroid cancer, right? Calcitonin. And then follicular cells, that's also going to just be in the thyroid as well. That's thyroid hormone. All right, wrong gland. But again, chromaffin cells, those are going to be the guys that's releasing too much of these catecholamines. All right. Okay, let's move on to number 9. We have a 23-year-old woman that presents with heat intolerance and exophthalmos. Labs show suppressed TSH and elevated T4. Which mechanism best explains her eye findings? So whenever we're thinking about an issue with exophthalmos, there's really only like a couple things. If anything, there's one thing I can name off the top of my head that'll cause it, and this is Graves' disease. All right. Graves' disease is going to cause the exophthalmos. You're basically having too much hormone production, and it's a point where you cannot control it because there's antibodies that are activating the receptor, and they're causing too much proliferation and growth of some of these tissues, and you're going to have too much edema in some of these areas, right? And so what's happening here is that you'll have what we would consider fibroblast stimulation by these TSH receptor antibodies, and you're going to have too much tissue proliferation in these areas. All right. And the one downside is there's probably some medications they're trying to come out with nowadays, but exophthalmos is pretty permanent. That's one of the symptoms or signs that you cannot take back. You can take away all the hyperthyroidism by giving the patient PTU, methimazole, that kind of thing, giving them beta blockers, giving them things that'll try to help with the fact that they're producing too much thyroid hormone and the symptoms of having too much thyroid hormone. But for the most part, something like the exophthalmos is not something that you can kind of reverse. All right. Okay. Okay, let's continue. Question number 10. We have a patient with CKD that develops hypocalcemia. Which hormone level is expected to increase as a compensatory response? So patients with CKD are going to have a lot of issues, and hypocalcemia is technically a side effect of one of the other issues that it has, all right? And there's 2 different ways that this can happen, but both of them will kind of lead to the same exact thing. They'll both lead to the same exact thing. When you have CKD, you have kidney failure, essentially. This is chronic kidney failure is what we're talking about. When a kidney is failing, anything that's supposed to be produced by the kidney is not going to be produced anymore. That'll include things like EPO, right? So technically our kidney is supposed to sense our oxygen levels, and it's going to release erythropoietin depending on how much oxygen it feels like we have, and then that'll help us produce more red blood cells. That includes things like vitamin D activation with 1-alpha hydroxylase. So not that I'm recommending this, but for patients with CKD, if they could get something like sarcoidosis, then they'd have enough alpha hydroxylase to activate vitamin D and get more of that calcium back in their system. But no, do not do that. That's another thing that'll be knocked out in patients who have CKD. And then the big thing is, as well, is you're not going to be able to reabsorb or get rid of the appropriate electrolytes. So you're going to have electrolyte abnormalities. All right. And both of these 2 options lead to the same exact mechanism. When we have an issue with 1-alpha hydroxylase, that means we're not going to be able to activate vitamin D. Typically, we're supposed to activate vitamin D. If we can't, no vitamin D means no calcium. So we're going to have very low calcium. This calcium is coming from our diet, from our bones, right? Vitamin D is supposed to be activated and then reabsorb it from our diet, bones, etc. Even in the kidney, all that is supposed to be activated in terms of giving back calcium into the body. We can't do that. At the same time, if we have electrolyte issues, for example, typically we're going to have issues always with potassium. Potassium's the really deadly one that we're always like, oh yeah, they're going to get torsades. But phosphate, right? If we have really high phosphate in patients with CKD, then in phosphate issues, phosphate likes to bind calcium, right? When it goes around in the blood, it likes to bind calcium. And what did I say earlier? We only respond to the free levels of things. If you have a lot of phosphate, phosphate's going to be binding a lot of calcium. We're not going to feel like we have a lot of free calcium that we're going to be able to do stuff with. So in this case, it's going to drive down our calcium levels, and it's going to look like we have hypocalcemia. Both of these mechanisms will tell our body to say, hey, let's secrete PTH to try to compensate. If we start secreting PTH, hopefully we can overcome it, and we can't, because PTH is going to try to activate more of the vitamin D, and vitamin D can't be activated because you don't have 1-alpha hydroxylase. So at the end of the day, you're going to try to secrete a lot of PTH, and it's not going to do anything. All right? Okay, we've gone through our first 10 questions. How do we feel so far? Speed-wise and question-wise, answer-wise. Okay, perfect. Just want to make sure. Usually I'll stop every like 10 questions or so, or 20 questions, just to kind of check in like how people are feeling, but good. All right, let's keep going. Question number 11. We have a 38-year-old man that presents with recurrent kidney stones and peptic ulcers. Labs show hypercalcemia and elevated gastrin levels. Family history reveals his father had a pituitary tumor. Which genetic mutation is most likely responsible? So if we have hypercalcemia is typically going to come from one place and one place only, and it's going to be some sort of parathyroid issue. So let's just say parathyroid. If we have elevated gastrin levels can be from some sort of tumor in our pancreas, right? Pancreas, if we have some sort of Zollinger-Ellison syndrome, right? So we'll have a pancreatic issue, tumor, right? And that would result in the Zollinger-Ellison syndrome. And then dad had a pituitary tumor, right? And they're telling us that dad had some sort of pituitary tumor to kind of infer that this is genetic, right? If we have this triple P combination of things that can go wrong, this is one of our MEN syndromes. So let's kind of talk real quick about the two different MENs, and then technically MEN2 has two different subsets. So there's MEN1, which is exactly this trifecta right here. So this is actually the MEN1 tumor suppression mutation. And then there's MEN2B, 2A and 2B. So if we do MEN, let's make this a different color so it's not confusing. MEN2A, and then MEN2B. Oh, I should have said or not 2B for the first one. Okay, sorry. So MEN2A. For 2A, I like to remember it as PTH, parathyroid hormone, easy enough to remember. But in this case, it's going to be a pheochromocytoma, thyroid, and it's specifically medullary thyroid carcinoma. And then hyperplasia of the parathyroid gland. That's going to be your MEN2A symptoms. MEN2B, very similar start, pheo, thyroid, and then the same thing. And then on this side, we're going to have PTN, where we're going to have neuromas as our third thing, all right? And aside from that, typically these patients will also have a marfanoid appearance. So that's another way that you can kind of remember there's a difference. A few different things that'll cause you to have a marfanoid appearance. Marfanoid syndrome, obviously. Or Marfan syndrome, sorry. There's homocystinuria that can also cause you to have a marfanoid appearance. And the lens dislocation is how you'll differentiate between the two, right? Whether it's down and in, that's going to be homocystinuria. Up is going to be Marfan syndrome. And then something like MEN2B will also give you a marfanoid appearance. All right, but in this case, is going to be the MEN1 tumor suppression mutation, and that's why we're having this. All right. And these pancreatic neuroendocrine tumors are what's causing something like the Zollinger-Ellison syndrome. All right. Okay, let's move on to 12. We have a 24-year-old man that presents with polyuria and polydipsia after head trauma. So after some sort of polyuria, polydipsia, we're always thinking diabetes, but what kind? Or maybe some sort of other issue, but maybe this is diabetes, maybe not. I'll take that back slightly just in case, but usually it's going to be diabetes, and we'll try to figure out why. Serum sodium is elevated. So now that we have a serum sodium that is elevated, this is probably some sort of issue with maybe concentrating our urine, right? Urine osmolality remains low despite water deprivation, but increases after desmopressin administration. What is the most likely diagnosis? So I was right. This is one of the forms of diabetes, right? But in this case, when we're thinking of diabetes, we have to try to remember that there's diabetes mellitus and there's insipidus, right? Diabetes insipidus is that we don't have response to ADH. Mellitus is that we don't respond to insulin or don't have insulin. ADH is that we don't, insipidus is that we don't make ADH or respond to ADH. So let's talk about central and then nephrogenic. Central diabetes insipidus is that we can't make ADH. Common reasons why this will happen: head trauma. Oh boy, didn't this guy just have head trauma, right? So we're not going to make ADH. This one will respond to desmopressin, right? Desmopressin is basically going to be giving back this patient some sort of ADH, right? If we're thinking of nephrogenic, no response to ADH. So we can make it, we just can't respond to it. Obviously, it's not going to respond to desmopressin. All right. All right. So in this case, this patient is not responding to desmopressin. Sorry, is responding to desmopressin, but they weren't responding after the water deprivation test. This is central diabetes insipidus. All right. The reason they're not responding to the water deprivation test is because we can't have any type of concentration of our urine when we have central diabetes insipidus. If we were thinking something like SIADH and then issues with that, not only would SIADH have a high urine sodium, not a low urine sodium, but in that case, when we give them something like water deprivation, it would start to correct their serum issues in terms of sodium. All right. Okay. Let's keep going on to number 13. We have a 70-year-old woman with small cell lung carcinoma that develops confusion. Labs show hyponatremia, low serum osmolality, and high urine osmolality. Which mechanism best explains this? I just kind of said this in the last question, but whenever someone has issues with concentrating their urine, there's two different routes. There's either too much concentration of urine, which too much is going to be that SIADH route, and then not enough concentration is going to be the central diabetes insipidus or nephrogenic diabetes insipidus. This patient has high urine osmolality, likely more that SIADH route. I wonder which one of the lung cancers can cause SIADH. Gee, maybe it's small cell lung carcinoma, right? So if we're thinking of what types of cancers can cause what, I'll just do a quick little recap just so you guys can remember. Squamous cell carcinoma is going to cause the PTH-related peptide release. That's basically it. Small cell lung carcinoma is going to cause ACTH release, SIADH, and you can also get Lambert-Eaton syndrome, right? A lot of people are going to remember the Lambert-Eaton syndrome one and forget that it can also release some of these other hormones. So in small cell, you can also have the antibody towards presynaptic calcium receptors, and then you'll result in Lambert-Eaton myasthenic syndrome. All right, but this is SIADH. In SIADH, we're going to be causing too much concentration of our urine, right? And with that being said, when we're considering what is the actual mechanism, This is that we have too much ADH secretion. So we have ectopic ADH production, right? In the other cases of diabetes insipidus, we're either not making it or not responding to it. Now we just have too much going on, all right? So in this case, this is the exact opposite mechanism from when we were thinking of diabetes insipidus. All right. Cool. Let's move on to 14. We have a 52-year-old obese man that presents with fasting hyperglycemia. Insulin levels are elevated. Which of the following is the primary defect in early type 2 diabetes? So remember, we were talking earlier about type 1 diabetes and type 2 diabetes, all right? Type 2 diabetes, they're already telling us that this patient probably has type 2 diabetes, and they're asking us what's the deficit. We know that it's type 2 anyways, though, because we see that they have hyperglycemia. They have probably some sort of baseline obesity, although it's not required, especially nowadays with the access to sugary foods that we have. You can get so many glucose and insulin spikes over time that even patients who seem to have relatively normal or just above normal BMIs may also have diabetes as well, type 2 diabetes. But for the most part, whenever we're thinking of type 2 diabetes, we have an issue with our insulin sensitivity, right? And it's because we start having peripheral resistance to insulin. This is where our body can make insulin. So we're able to make insulin. And we probably even make a lot of insulin, but we can't respond to it. There's no response. So now we'll have hyperglycemia. And our body will actually still go into this like fight or flight mode where it's going to try to release glucagon or all these other things to say, hey, we need to produce more glucose because we're running out of glucose, even though our glucose is at like 900. All right. So that's the big thing here. Type 2 diabetes, we have insulin resistance. All right. And that's just because over time, so much insulin is released because we have these glucose spikes that your body just kind of gets used to it, right? Kind of gets acclimated to it. All right. Let's move on to question 15. Halfway through our first block. We have a patient that develops perioral numbness and muscle spasms after thyroidectomy. Labs show low calcium and low PTH. Which of the following findings is expected? So the number one cause of hypoparathyroidism, and I'm kind of giving away the answer here, but this is why I'm mentioning it. The number one cause of hypoparathyroidism is iatrogenic injury or release, that kind of thing. It's iatrogenic causes, specifically a surgical removal or injury. So for those of you who remember your anatomy, the thyroid gland is kind of sitting in front of the cartilage, right? And then the parathyroids are just sitting on the back, and there's like 4 glands, right? They're sitting on the back. They're parathyroid, right? Aside from the thyroid, essentially. They're sitting on the back. And when you remove the thyroid, you can accidentally kind of take all the parathyroid tissue with you. And if you do that, now you're going to have hypoparathyroidism. So you're going to have decreased calcium levels in the body, also decreased PTH, which they made sure to mention that. You're not going to have parathyroid hormone. And then what are the symptoms that we would expect? Perioral numbness, muscle spasms, sure. But what are the signs that we're going to look for? There's 2 different signs. There's Trousseau's sign. Not Trousseau syndrome, just the sign. Syndrome is when we have the thrombophlebitis migrans, in which case that's probably some sort of visceral adenocarcinoma. But in this case, Trousseau sign, and then Chvostek sign. What are these? Trousseau, that's when you have the blood pressure cuff, and then suddenly they have wrist spasm. And then Chvostek sign, that's when you flick the cheek. And then you have cheek and lip spasm. So just to kind of show you, it's when you kind of flick the side of their face, their cheek, and then suddenly their cheek and lip area start kind of twitching because of the hypocalcemia. All right. All right. So in this case, what do we have going on as our main mechanism of what could be happening since we don't have the PTH secretion? It's likely going to be increased phosphate. Because in this case, when we have issues with our PTH secretion and all that kind of stuff, Well, parathyroid hormone is typically going to increase calcium reabsorption and decrease phosphate reabsorption. We don't have parathyroid hormone anymore. So since we have less parathyroid hormone, now we're going to result in less calcium reabsorption and increased phosphate reabsorption. So in this case, our final answer is that we're going to have increased serum phosphate. All right. Okay. And then, yeah, just the diagram. Here's the little parathyroid glands that I was talking about, and that they are very easily injured or removed when we have thyroidectomies. All right. Okay. Let's move on to 16. We have a 60-year-old woman that presents with bone pain and recurrent nephrolithiasis. Labs show hypercalcemia, low phosphate, and elevated PTH. What is the most likely cause? So in this patient, we have a very classic triad of just high calcium, low phosphate, and increased PTH. We just said how PTH, the hormone itself, is going to cause increased calcium reabsorption and decreased phosphate reabsorption. Well, is that what we have for a mechanism going on? Yeah, we have hypercalcemia, low phosphate, and elevated PTH. So in this case, this is just primary hyperparathyroidism. Our patient just has too much parathyroid hormone release. If we were considering something like secondary hyperparathyroidism, in which case our kidney is starting to fail, we would have elevated PTH secretion, but likely normal to low calcium levels, right? Because in that case, our kidney is starting to fail in terms of its 1-alpha hydroxylase use and the activation of vitamin D, so we wouldn't be able to keep up, all right? Okay. Then the bone pain, the bone stones, groans, and then you can even have psychiatric overtones. In that case, these are all the different things that hypercalcemia can cause. Bone pain because you're reabsorbing all the bone. Stones because you have so much calcium that you're going to have kidney stones. Groans because you have abdominal pain from everything going on. And then even eventually psychiatric overtones with the fact that too much calcium, you can even have neuro dysfunction. All right. Okay. Let's move on to question 17. We have a 40-year-old woman presents with fatigue, weight loss, and hyperpigmentation of her skin. Labs show hyponatremia, hyperkalemia, low cortisol, and elevated ACTH, which is the most likely diagnosis. So we were talking about earlier, whenever we have our system of being able to make aldosterone, cortisol, right? We start with cholesterol, and then we end up with, they might be a little too close, but aldosterone, cortisol, androgens, and we'll have a fourth thing that we're going to make, but this has nothing to do with this normal pathway. If we have a lot of ACTH, ACTH is typically going to stimulate just cortisol, but if you can make aldosterone and you can make androgens, typically sometimes the ACTH can just cause gland hyperplasia in general. But in this case, this specific person, they're going to have adrenal insufficiency where they can't make any of the aldosterone or cortisol. So that's why they have hyponatremia, hyperkalemia, and low cortisol. Why do they have hyperpigmentation? Because ACTH is just going to be floating around the body. It's not like it just stays in the adrenal gland waiting for something to activate it. It floats around the body. You're actually going to stimulate melanocytes. And they'll start producing melanin, and that's how you get the hyperpigmentation. So in this case, the primary adrenal insufficiency, Addison disease, not syndrome. Addison disease is sometimes what they'll call it. And that's typically what you'll have where you can't make aldosterone and cortisol. And so suddenly you shunt everything towards making melanin. And not that you mean to, but you just can't really control it. All you need to do is give them back. This is more of a step 2 type area, but all you need to do is give them back the hormones they don't have. So cortisone, you can give them steroids, and then you can also give them fludrocortisone. That'll be the aldosterone aspect, right? So glucocorticoids and mineralocorticoids. All right. Okay, let's move on to 18. We have a 29-year-old woman that has untreated hyperthyroidism and presents with fever, agitation, tachycardia, and vomiting after surgery. Which mechanism best explains her condition? So whenever someone has this issue of hyperthyroidism right after surgery or right after being like very sick or something, and this is very clear hyperthyroidism and like some really bad symptoms of like fever, agitation, tachycardia, right? This is what we would consider thyroid storm. Okay. Thyroid storm can get pretty bad sometimes. Their tachycardia goes through the roof. They can't really stop their heart rate. It's going to be, like 180 or something. Their blood pressure is going to be through the roof. And what's happening is that we just have a huge amount of stress on the body. In thyroid storm, that huge amount of stress is going to result in sudden release of the preformed thyroid hormone. And that's going to cause a huge difference, right? Thyroid hormone, it's a beta 1 agonist. So we're going to cause a lot of increased contractility, increased heart rate, right? And in this case, we're going to have issues with trying to reduce the patient's heart rate. We're going to have to give them a ton of propranolol, that kind of thing, and potentially even some PT or methimazole just to try to bring down the thyroid hormone levels in general in case there's something going on. All right. Okay. And then let's move on to our last one of our thyroid or our endocrine block. Sorry, this is not the last one. Two more in our endocrine block. That's 19. We have a newborn that presents with hypertension and ambiguous genitalia. Labs show low cortisol, low renin, and increased 11-deoxycortisol. Which enzyme deficiency is most likely? So I was talking about this one earlier. Again, we start with our precursor molecule, cholesterol. We're going down our paths, right? We have aldosterone here. We have cortisol here. And then androgens here. So in this case, we have a mechanism where we have too much 11-deoxycortisol, but for some reason, even with low cortisol, low renin, we still have high blood pressure. So what do we think is going on in terms of our overall hormone productions? Well, in this case, when we have the high 11-deoxycortisol, this looks like some sort of mineralocorticoid activity because we're getting far enough into the aldosterone pathway where it actually can help still stimulate aldosterone receptors. So we're still going to have aldosterone-like activity. And if it's all we can produce because we still can't produce cortisol, then we're just probably going to produce a lot of it because every time our body says, hey, we need cortisol, let's increase our ACTH production, and then we can't produce it, then our body's just going to start making a lot of this hyperplasia in the adrenal gland. We're probably going to start making a lot of this 11-deoxycortisol. So we're probably going to have a lot of this activation of these aldosterone receptors. So this is what we would consider the 11-beta hydroxylase deficiency, right? So in this case, this 11-beta hydroxylase deficiency, it stops us here, but it's far enough into our aldosterone pathway where we still have aldosterone receptor activation and we can still have hypertension from it, all right? The one downside is that typically you're going to have to supplement them with cortisol in order to get them above the hump because increased ACTH production, they're still going to have hyperplasia of the aldosterone type side. That's why their renin is low, right? So typically renin is supposed to control how much aldosterone we secrete. And in this case, it's ACTH driven because the gland as a whole is just kind of secreting a ton of it. All right. Let's move on to our final question of the endocrine side, right? We have question 20. We have a 45-year-old man presents with enlarged hands and jaw. Labs show elevated IGF-1 levels. Oral glucose fails to suppress growth hormone. What is the most likely cause? So whenever we have an older person, 40s, 50s, not older like elderly 80, but like 40s, 50s coming in, and they say, yeah, my clothes don't fit anymore, and your immediate guess is, oh, they probably just gained some weight. No, they'll say literally, like, my arms are weirdly not fitting into things, my hands are too big, my jaw doesn't fit. Maybe they play football or something, they wear some sort of strap around their jaw, it doesn't fit anymore, their hat might not fit anymore. They have some of these bones that kind of just grow a little too big. And then they'll also complain about symptoms of something like diabetes, and it's because in these kinds of patients they can have some diabetes. This is going to be acromegaly. In patients with acromegaly, they have a tumor that's secreting too much growth hormone, right? So this is going to be considered a growth hormone secreting pituitary adenoma. because they're secreting too much growth hormone. Growth hormone, the mechanism in terms of everything going on with IGF, it's going to hit to the liver. That's going to cause increased secretion of IGF-1. And then that's eventually going to cause the tissue growth. And that's why this patient is going to get bigger in general. And then they're also going to have issues with diabetes. The oral glucose suppression test is supposed to suppress growth hormone in general. When it doesn't, that's officially confirming acromegaly. So no response to oral glucose. Oral glucose. All right, so that's how you confirm the diagnosis of acromegaly. So in this case, a pituitary adenoma is what acromegaly is going to match with. All right. Okay. And then now we'll move on to our next section of GI questions, just to check in though. Questions so far? Any questions on anything we've done so far or how we're feeling? How are the first 20? All good. Cool. All right. Let's continue. Oh, I can't charge it and use it at the same time? That's fine. Cool. There we go. It's back. Okay. Question number 1 from the GI section. We have a 46-year-old man that presents with progressive dysphagia to both solids and liquids over 8 months. So solids and liquids, when we have dysphagia to both of them, that's typically going to be a red flag that we have something blocking the entirety of our esophageal lumen, right? If we have dysphagia just to solids, you can get away with some amount of dysphagia to solids and it won't be some sort of extreme thing. But whenever we have dysphagia to solids and liquids, that means that nothing can get down. There's probably some sort of issue of either there's a massive tumor at the bottom or we literally cannot open our lower esophageal sphincter at all. All right. So let's see what they're having in terms of symptoms to see what it'll match. He reports regurgitation of undigested food and chronic cough at night. He has lost 10 pounds. A barium swallow shows a dilated esophagus with smooth tapering at the gastroesophageal junction. Esophageal manometry demonstrates incomplete relaxation of the lower esophageal sphincter and an absence of peristalsis. What does all this mean? So if we have a very dilated esophagus and then it suddenly just like tapers off, I think the fact that I kind of drew this way makes everyone kind of realize, oh, I know what that looks like, right? The bird's beak appearance and what the bird's beak appearance actually means. So in this case, we have an issue with relaxation of our lower esophageal sphincter. That's why they say an incomplete relaxation. That's going to match the mechanism of achalasia, right? And what is achalasia? Achalasia is the fact that we have an issue with relaxation of the smooth muscle of the lower esophageal sphincter because of the neurons, right? The neurons are supposed to offer some sort of mechanism to try to relax those muscles, but we can't. And so they're always going to be tight. And it's the same thing with the back end of the stomach, right? Both ends of the stomach have some sort of neuron induced mechanism to relax. So our pyloric sphincter is supposed to open after we have that vagal input, right? The vagus nerve is supposed to tell it, hey, you need to open now. And if it doesn't, then we have some sort of issue there. And sometimes when you have a Whipple surgery, what you'll do is you'll actually cause, you'll do a vagotomy at that end, or you'll cut open through the muscle just to kind of let it release at all times, because you're not going to have the same input for the nerves. That plexus isn't going to be there, so you just need to kind of allow it to dump, and you're going to need to give the patient PPIs chronically to make sure they're not burning through their whatever's left of their duodenum or jejunum, whatever is connected, attached to the stomach directly. But that's too far into another realm. Let's keep going back to this achalasia side. So in this case, this is going to be degeneration of our plexus, and this is because we're not having the same input anymore. If you're thinking of something like some sort of Zenker diverticulum, we could have undigested food come back, but it wouldn't be this like great issue of the dilated esophagus, smooth tapering. If it was some sort of adenocarcinoma, you wouldn't have the smooth tapering at the bottom. And then the issue with peristalsis, right? This is really confirming the achalasia. And then what is the mechanism of achalasia? It's the fact that we have an issue with the neurons, all right? Okay, let's move on to the second one. We have a 58-year-old man, comes in with chronic heartburn, and presents with worsening dysphagia. Endoscopy reveals salmon-colored mucosa extending proximally from the GE junction. Biopsy shows intestinal metaplasia with goblet cells. Which of the following malignancies is this patient at highest risk of developing? So, a patient who comes in with GERD, which is that chronic heartburn, and then suddenly has this intestinal metaplasia with goblet cells, this is what we would consider Barrett's esophagus. All right. Barrett's esophagus is when we have this intestinal metaplasia, because typically our esophagus is supposed to be squamous cells. You're going to have squamous epithelium. And then these squamous cells, over time, as they're exposed to more and more acid, are going to say, hey, can we just like change into another cell type that can actually respond to acids well, because we're getting like destroyed here, right? So they're going to actually become the columnar cells, right? Columnar is what we have in our stomach. The columnar is allowing them to have these goblet cells, right? And that's where they can secrete mucus, and it's going to have that protective layer so they're not just getting destroyed by how much acid we're producing in GERD. Well, in this case, when we have this transformation from squamous cells to columnar, this is what we would consider Barrett's. That metaplasia is what Barrett's is. This is metaplasia, when we're changing cell type. Not metaphasia, metaplasia. Oh, throwback to metaphase, right? Oh, those good old days with just cell division when we thought that was the hardest thing we're ever going to have to learn. All right, so metaplasia, in this case, when we have metaplasia and we turn into Barrett's, well, we could actually then have complete change where we're going to have issues with potentially having adenocarcinoma of the esophagus, all right? When we're thinking of the cancer types as well, adenocarcinoma is typically because we have some sort of chronic GERD, and it's going to be at the lower esophageal area. But in terms of the different types of cancers that can occur, it's broken down by the top 2/3 esophagus, and then the bottom 1/3 of the esophagus. All right. The bottom 1/3 is typically always going to be adenocarcinoma, and it's typically always going to be related to some sort of chronic GERD or something, some sort of acid issue. The top 2/3 is going to be squamous cell, because we don't have the metaplasia mechanism the way that we have with GERD. Squamous cell is what normally is in the esophagus, and in these cases, the squamous cell carcinoma is going to be due to a few different things. Alcohol can be related, smoking especially. Smoking causes every type of cancer you can probably think of. Yes, it probably causes whatever you're thinking of right now. And then also hot teas. So this is why Asian communities or any individual that drinks hot tea is going to be at risk of getting squamous cell carcinoma. And it's typically because we're going to be shedding a lot of layers of these squamous cells. Hot teas are going to be scalding the top layer of the squamous cell. You're going to have to replace it with another layer, right? And every time that you need to divide a cell, there's just that much more risk in terms of having cancer happen, right? So every time a cell has to proliferate, the risk of cancer is ever so slightly stronger than if we didn't have to proliferate, right? So typically, cells that never have to proliferate in their life, things like neurons, things like that, where they rarely ever proliferate, they're probably not going to have that much risk of cancer. That's why brain tumors aren't going to be as common as things like melanomas or skin cancers, right? Because skin is always kind of dividing, until you get really, really old, where then it's like really, really thin and poor skin, just because the cells probably aren't dividing as well as they should. But skin is always dividing. That's why you're having a much higher risk of skin cancers compared to others. All right. Let's move on to question 3. We have a 42-year-old woman that presents with epigastric pain that improves with meals, but returns 2 to 3 hours later. Endoscopy shows a duodenal ulcer. Biopsy reveals a spiral-shaped gram-negative organism. Which mechanism most directly contributes to the ulcer formation in this patient? So, whenever we think of pain with or without meals, whether it happens after you fast for a while or don't fast for a while, this is what we would consider some sort of ulcer. And let's talk about what our 2 different types of ulcers are. So we have duodenal, and then we have gastric, right? And then let's talk about whether or not there's pain with meals or pain without meals, right? So pain with, or sorry, let's talk about meals or fasting. Let's do it that way. Meals, fasting. All right. So with duodenal ulcers, that means we have a lot of pain when we fast, because typically as we fast, there's going to be a slight release of hydrochloric acid from our stomach over time, and that acid is going to make it into our duodenum, and then it's going to cause issues where it's going to burn the ulcer for one, and then two, duodenal ulcers are typically also related to H. pylori, which is actually what this patient has. There's probably H. pylori. H. pylori has urease, right? Urease is going to help H. pylori break down the hydrochloric acid and allow it to live in that acidic environment. So we're going to have pain with fasting. Why don't we have pain with meals? Why is it pain relief? Well, in this case, what type of secretion comes out of the pancreas when we eat food? It's going to be a bicarb rich, bile rich, right? Things that'll help calm down the hydrochloric acid. So when we eat food, we're going to have secretion of all these different molecules and enzymes that'll help break down the hydrochloric acid or prevent it from causing any damage. So it's going to feel good when we eat. So the patients who have duodenal ulcers, and I'll just add this last column of weight. Patients who have duodenal ulcers are going to have weight gain because it's going to feel good when they eat. It's going to relieve the pain, so they're going to eat a lot. Gastric ulcers, when they have meals, this will cause a lot of pain because now the ulcer is inside the stomach lining. The stomach lining is now going to be irritated. When you eat food, you're going to release a lot of hydrochloric acid, way more than before, right? The problem with fasting is that you're not making too much hydrochloric acid, but if anything, some of it will still get released into our duodenum with time. So the more you fast, the more hydrochloric acid will get released, the more pain you have. In this case, when the ulcer is in our stomach, as you eat, you'll have a lot of increased acid production. When you fast, it's going to relatively decrease how much acid production there is. So fasting will cause pain relief. And your weight is going to be based off of when you feel good. Meals and duodenal ulcers will cause pain relief, so you're going to gain weight. Fasting and gastric ulcers will cause pain relief, so you're going to lose weight. If you have weight gain in duodenal ulcers, weight loss in gastric ulcers. So in this case, again, I mentioned H. pylori is the main mechanism, and that's why we're saying we have a spiral-shaped gram-negative organism. H. pylori is the main mechanism of what's causing this duodenal ulcer. And so in these patients, anytime you consider someone might have a duodenal ulcer, and you'll ask their symptoms and see when they have pain relief or pain, that kind of thing, then you're going to do a biopsy before you do any treatment, because if you give them even a PPI, that might cause a false negative for a breath test, right? Because a PPI is going to cause us to release less hydrochloric acid. Hydrochloric acid should be being broken down with the urease that H. pylori has, and now we can't get the ammonia product that we're trying to sense when we do the breath test. All right, so in this case, we're always going to try to do a biopsy before we treat them. Okay. Let's move on to question 4. Ooh. I'm trying to make sure I'm in the circle. All right, cool. We have a 23-year-old woman that presents with chronic diarrhea and weight loss. Colonoscopy reveals continuous mucosal inflammation beginning at the rectum. Biopsy shows crypt abscesses and mucosal ulceration. Which extraintestinal manifestation is most strongly associated with this disease? So when we talk about continuous mucosal inflammation, and we're talking about chronic diarrhea and weight loss, I guess just in general, chronic diarrhea and weight loss, and in a pretty young person, we'll probably be considering Crohn's and then UC. All right. Crohn's versus UC, what are our major things that we're considering? In Crohn's, this is when we have the skip lesions, right? UC is continuous, starting at rectum. So this answer is going to be UC, and then we'll talk about what UC is associated with. All right. From there, Crohn's is also associated with completely like through the wall transmural inflammation. You'll have fistulas, entire wall inflammation, transmural, and then this one is just superficial inflammation. Typically, UC is also going to be the one that's bloody. Crohn's is not going to be bloody that often. All right. And then I think those are some of the main things that we'll consider in terms of Crohn's versus UC for what we're going to see. And then in terms of what kinds of extraintestinal manifestations, UC is going to have erythema nodosum. Erythema nodosum is when we have those large leg wounds that we're considering. It'll also happen in things like histoplasmosis, right? But typically, when we think of erythema nodosum, we're also going to be expecting, when we think of UC, we're also going to be expecting erythema nodosum. We're also going to be expecting PSC, right? Crohn's is going to have PBC, primary biliary cholangitis. UC will have primary sclerosing cholangitis. So UC, you're going to expect like a middle-aged man. And then Crohn's will be a younger female. Those are typically who's going to get the PSC versus the PBC, all right? But erythema nodosum is the best way to think about it. B12 deficiency is when you have something like Crohn's, just because typically Crohn's will also involve small intestine. And anytime you have small intestine, you might have issue with things like B12, B9, iron, depending on where it can happen. And Crohn's can happen anywhere along the GI tract from mouth to anus, is what they'll say. So you can even have lesions in the mouth. UC is just in the distal colon. And if it's the entire large intestine, the colon, then you would call it pancolitis. But still, it's just the colon. All right. And it's on fire, just to kind of get that nice little diagram there. All right, let's move on to 5. We'll do a few more questions and then we'll take a quick little break. We have a 27-year-old man that presents with chronic diarrhea and abdominal pain. Colonoscopy reveals skip lesions and transmural inflammation. I wonder what this one is. He has recurrent perianal fistulas. Which region of the GI tract is most commonly affected? So now we're thinking of the exact opposite, right? We have fistulas. We have issues with transmural inflammation, right? So which one of these areas is most commonly affected? We were talking about earlier what type of vitamin we might have a deficiency in, right? B12 is going to be an issue with Crohn's disease. This is Crohn's. And where is B12 reabsorbed? That's terminal ileum, if you guys remember, right? So the most important part that's going to be affected typically in Crohn's is our ileum, all right? And that's just, if you can try to remember, B12 deficiency is very common in Crohn's disease, then hopefully that'll help you remember which part is going to be affected for the most part, okay? Let's move on to number 6. We have a 6-year-old boy that presents with chronic diarrhea and failure to thrive. Anti-tissue transglutaminase IgA is positive. Small bowel biopsy shows villus atrophy and crypt hyperplasia. Which nutrient deficiency is most likely? So now when we have this patient who has villus atrophy, I think everyone in the world is going to understand that villus atrophy is probably going to be celiac disease, right? And that's why they have the chronic diarrhea. Failure to thrive, just because we can't absorb some of those small sugars, right? Typically that the villi, right, that villus border that we need, that brush border enzyme is going to be where we absorb a lot of different things. But this brush border deficiency with this villus atrophy is also going to affect our intake potentially from one of these different vitamins or metals that we need in our body, right? So when we have transglutaminase, IgA positive, we're destroying that brush border, we're not going to be able to absorb iron, right? Iron is absorbed early on, right? Typically iron is absorbed, it's the, if I'm not mistaken, duodenum. I'm trying to think now. But in terms of our small intestine, iron is absorbed very early, and we're going to have issues with celiac disease in terms of our absorption in that small brush border enzyme area, right? So we're going to have issue with iron. Things like vitamin K, B12. B12 is later on, and that's typically going to be terminal ileum. That's too late. If we're thinking of vitamin K, that's going to be one of our fat-soluble vitamins. Doesn't have anything to do with this. So these other guys aren't really going to match. It's the fact that iron is absorbed pretty early, and celiac disease is affecting our small intestine. All right. And I was right. It was duodenum. All right. So let's move on to question number 7. All right, we have a 50-year-old man with a history of heavy alcohol use that presents with severe epigastric pain radiating to the back. Serum lipase is elevated. CT scan shows pancreatic inflammation. Which enzyme activation initiates the disease process? So whenever we're thinking of someone drinking a lot and then having back pain, right, that mid-epigastric pain, severe epigastric pain to back pain, this is probably some sort of pancreatitis, right? And then when we're thinking of pancreatitis, we're nervous that they may have leakage of a lot of different enzymes. Pancreatitis. They're going to have release of a lot of enzymes, including lipase and amylase, right? And then typically how we would diagnose it is 3 times normal. 3 times normal is going to be pancreatitis. All right. But is that what's causing the initial activation of this disease process? It's not. Because lipase and amylase are not the initial part of the entire mechanism. There's something else that's actually made first. And that is what's releasing a lot of the lipase or causing the lipase to actually be activated, right? So if we have premature activation of something like trypsinogen, trypsinogen is going to activate trypsin. And trypsin is what's going to ultimately cause the... Nope, let's not do that. Let's do this. Trypsin is ultimately what's going to activate the mechanism for everything else. So trypsin activation is the core mechanism for why a patient will end up with pancreatitis, because they have premature activation, trypsinogen to trypsin, and then everything else in the cascade is going to get lit up. All right. And then for these guys as well, just to kind of give like a quick little tidbit as well, when you have chronic pancreatitis, so patients who are chronic alcohol users and they have chronic pancreatitis, they're going to be at increased risk of something like a calcium, right, a calcified pancreas, calcified pancreas. That's going to increase your risk of like pancreatic adenocarcinoma, that kind of thing. So chronic pancreatitis, you're probably going to be at risk of pancreatic cancer as well. All right. All right, let's move on to 8. And we'll do 3 more and then we'll take a break. A 55-year-old man with chronic alcohol abuse that develops steatorrhea and weight loss. CT scan shows pancreatic calcifications. Which mechanism best explains his fat malabsorption? So I was mentioning earlier that the pancreas has a lot of enzymes that are getting secreted, as well as the bicarb in order to help with the hydrochloric acid, but it also has a lot of enzymes that are secreted. Those enzymes that are included are going to be our fat absorbing enzymes, right? Or the fat breakdown enzymes. Lipase is going to help break down fat. And if we aren't secreting lipase, then we're not going to be able to absorb fat. So in patients who have pancreatitis, we have decreased pancreatic lipase secretion, and that's going to cause more fat in our stool. And fat stool is what we would consider steatorrhea. And steatorrhea, you're going to know it because it's going to smell really bad. It's going to float. It's going to be pale. And it might even look oily. Like if you look, you can look like there's probably like a barrier around it sometimes. And you can tell there's actually oil that looks like it came out with the stool. All right. And it's typically going to be diarrhea. It's not really going to be a formed stool. It's going to be more diarrhea. All right. But decreased lipase production is why we're having steatorrhea. All right. Let's move on to number 9, our second to last one before the break. We'll have a 48-year-old obese woman that comes in with right upper quadrant pain after fatty meals. Ultrasound reveals gallstones. Which factor most directly promotes cholesterol stone formation? So we have an acronym that we typically remember in patients who are the 4 F's in terms of their gallstone risk. And it's going to be patients who are fat, female, fertile, and 40. This is our acronym of people who are going to be at risk of cholesterol gallstones. All right. And the mechanism here, obesity, obviously you're going to have more cholesterol. Females, estrogen, the way that things work are modulated. You're going to have an increased risk. Fertile, again, estrogen. And then 40, typically at that age range, is for some reason they're going to have a higher risk of getting gallstones in general. All right. And what are we having as our mechanism? It's super saturation of bile with cholesterol. That's why after fatty meals, there's worsening, because fatty meals, obviously, fatty meals are going to trigger a lot of CCK and bile release, and CCK is going to promote the gallbladder to contract. And in that case, if we have a lot of gallstones, it's going to be painful, but it's also going to promote more gallstone formation when you eat foods that are very high in fats and cholesterol in general. All right. And then again, the risk factors: female, fat, 40, fertile. And then let's move on to our final question before a quick little break. We have a 54-year-old man with cirrhosis that presents with hematemesis. Endoscopy reveals dilated veins in the distal esophagus. Which vascular change is responsible? So whenever someone has a dilated esophageal vein and they have hematemesis, and they come in with cirrhosis, we're probably going to be some sort of high risk, like, hey, I think this might be some sort of esophageal varices or something that's ruptured, right? But what is the mechanism? This has to do with our liver. And then you guys are probably in awe at how well I'm drawing this liver. This is our IVC, right? And then now we have our portal vein. And then we also have our hepatic vein, don't forget. Although the hepatic vein, you don't really even need. You could get rid of the hepatic vein, you'd probably still be fine. The portal vein actually gives the liver most of the oxygen it'll use. Probably more like 60 to 70% of the oxygen used by the liver comes from the portal vein. But for the most part, when we have cirrhosis, so we'll just kind of make this look like some crappy tissue in here, right? When we have cirrhosis, put in a bunch of different colors. Cool. This is a cirrhotic liver. We're going to have portal vein hypertension because not as much blood is going to be able to be filtered through the liver. This is when we say filter, this is why we have first pass metabolism. When we eat food, that food is typically going to go to the liver first. And then you're going to break down some of the actual food you ate. You're going to break down the medications, right? It's going to have that first pass metabolism first, and then it'll go into the body. It'll circulate around. Some of the things don't really matter for first pass metabolism because it might not be broken down by the liver itself, but we have first pass metabolism in general. If you have a backup from the portal vein, it's going to back up anywhere we have some sort of blood flow that's supposed to go to the liver first. What goes to the liver first? Anything in our GI tract from stomach to basically rectum. So if we have proximal stomach that's supposed to go to the liver, but then distal esophagus is not considered going to the liver first, that backup is going to make it where the esophageal veins meet the stomach are going to get dilated because that blood is going to want to go to the liver and it can't. It's going to be backed up. So we have portal hypertension causing dilated esophageal veins. And these are considered esophageal varices. Those esophageal varices are going to cause a life-threatening rupture if at some point the patient does have some sort of profuse vomiting or some sort of scratching and cutting of the esophageal varices. It's a very much life-threatening condition. You need to take them to endoscopy ASAP. Obviously, you'll stabilize them first, so that's more of a step 2 concept of making sure they have blood and fluids before you take them to endoscopy. But for the most part, the definitive treatment is endoscopy to try to tamponade, block off the esophageal varices that are bleeding. But there's going to be increased portal venous pressure that's causing this issue. All right. Next question. Number 31, technically 11, from the GI section. So we have a 32-year-old healthcare worker who's evaluated after a needle stick injury. Her labs show a surface antigen of negative, a anti-Hep B surface antibody that's positive, and then an anti-Hep B core antibody that's negative. So we're breaking down what these mean. Surface antigen means we have an active infection right now, because that's the surface antigen that's released by the Hep B virus as we're actually replicating it. All right. The Hep B surface antibody means we probably had either a prior infection or vaccine but it depends on what other things are positive. Okay? If it's only that, then it's vaccine. If we have a bunch of other things, then it could be the fact that we had a prior infection. And then if we have an anti-Hep B core antibody, this is definitely only infection. You only get it when there's an infection. All right. So in this case, we only have a patient that's positive for this marker and nothing else. So that likely means that the patient had some sort of vaccination against Hep B in the past, and that the needle stick didn't expose them to anything different. All right. If they had a natural infection, they would have Hep B core as well. If they had a window period infection, that's going to be a very specific thing where you would now have some sort of combination of potentially the E antigen, that kind of thing, right? But we don't have E antigen in our example. And then acute hepatitis infection, you might consider that the surface antigen would be positive. And chronic Hep B, again, that's when we'd have the Hep B E antigen positive, that kind of thing. Okay. And then window will have Hep B core IgM positive. Chronic will have the surface. And then Hep B E as well might be something that you'll consider as one of the things for chronic. Okay, let's move on to 12. So we have a 28-year-old woman presents with fatigue and jaundice. Labs show elevated AST/ALT. Anti-smooth muscle antibodies are positive. Liver biopsy shows lymphoplasmacytic infiltrates with interface hepatitis. Which of the following is the most likely diagnosis? So if you can remember which one of these antibodies causes what, when we have something like an anti-smooth muscle antibody, that's specific for autoimmune hepatitis. Right, autoimmune hepatitis means that we're going to have autoimmune breakdown of our liver, and we'll have high AST/ALT. How high? Probably greater than 1,000. What types of things are going to cause AST/ALT greater than 1,000? We would consider it VATS. So viral hepatitis will cause an ALT/AST greater than 1,000. Autoimmune will cause greater than 1,000. Toxic from a drug like acetaminophen. And then shock being from ischemia. Those are the 4 things that'll cause greater than 1,000 ALT/AST. If it's something else, probably not going to cause an ALT/AST greater than 1,000. You might want to change your differential. All right, so in this case, autoimmune hepatitis is what we're considering when we have the anti-smooth muscle antibody, right? If we're thinking of some of these other guys, we'd expect to see them have like PBC. We'd expect to see them have Crohn's or something, right? PSC, we'd be considering UC. Wilson disease isn't going to have this type of hepatitis type picture. You're going to have an enlarged liver because of the copper accumulation, but you're not going to have this true type of really bad AST/ALT elevation. And you'd also expect to see like neuro findings, maybe psychiatric findings, and be a younger male typically, not a female. And then alpha-1 antitrypsin, that's when patients have that liver and pulmonary involvement. It's going to be a young person. Sometimes it's going to be a smoker, although you don't have to be, but a smoker just because smoking will increase your risk of the alpha-1 antitrypsin deficiency having symptoms. But that's because you have the collagenase issues and things like that. But again, autoimmune hepatitis, very high ALT/AST because of the anti-smooth muscle antibodies. Let's move on to 13. We have a 40-year-old man with UC that develops fatigue and pruritus. Pruritus just means like itchy skin, itchy everywhere, that kind of thing. Labs show elevated ALK phos. MRCP demonstrates multifocal strictures and dilation of intrahepatic and extrahepatic bile ducts. Which malignancy is he at risk of developing? So, excuse me, sorry. When we have ulcerative colitis, and now we have these intra and extrahepatic duct strictures, this is what we would consider PSC, all right? UC is related to PSC, and this is one of those tests that you used to have. The GED, you'll have these, right? As Crohn's is to what, right? And then Crohn's is to PBC, right? So PSC is where we have this multifocal strictures of dilation, right? This is going to be like the beading, as they would call it, right? of the intrahepatic and extrahepatic bile ducts. You'll have an increased ALK phos, that kind of thing. And then which cancer are you more at risk of developing when you have UC and then you have this PSC picture? This is going to be cholangiocarcinoma. Cholangiocarcinoma, you're going to have more risk. And then if we're thinking of what you might present with when you have cholangiocarcinoma, you're going to have painless jaundice. And you're probably like, well, wait a second, isn't painless jaundice the symptom of pancreatic adenocarcinoma? It is. You'll have weight loss, painless jaundice, and you'll have these 3 types of cancers that can cause the painless jaundice, right? Number 1, first and foremost, pancreatic adenocarcinoma is going to be the most common. So if you ever have a question, you have a painless jaundice and you have weight loss, pancreatic adenocarcinoma is probably a good answer. Number 2, we just mentioned it as well, cholangiocarcinoma. And then number 3, adenocarcinoma of the ampulla levator. So this one's a very specific one, very rare. You're not going to have it all that often. But this is another one in which if you're blocking any release of the bile, then you're just going to have jaundice. All right. But again, PSC, you're going to have an increased risk of cholangiocarcinoma, and PSC and UC go together. All right. Let's move on to 14. We have a 17-year-old boy that presents with tremors and behavioral changes. Uh-oh, I may have given this one away in the last question. Exam shows scleral icterus and brownish rings at the corneal margins. Labs show low ceruloplasmin. Which mechanism best explains this? The brownish rings at the corneal margins, those are the Kaiser-Fleischer rings, because this patient has Wilson's disease. All right. Kaiser-Fleischer rings are those rings you'll see around the cornea. That's going to be the copper deposits that are depositing in the cornea. The low ceruloplasmin is because we have such high copper levels. And in this case, Wilson's disease is that we just can't move copper. We don't have a good channel for copper. When you're thinking of something like hemochromatosis, which is when we have too much iron, it's because we're absorbing too much iron in our diet. So there's a little bit of difference here. Wilson's, we can't move copper because we have a bad channel. Hemochromatosis is that we can't absorb iron, or sorry, we absorb too much iron in our diet, and in that case you have excess. And look, it's almost like they knew I was going to talk about the fact that hemochromatosis is an excess intestinal iron absorption. But in this case, Wilson's disease is issues with our copper incorporation into ceruloplasmin. And so that's why we're going to have issues with these copper channels, and we're not going to be able to use copper appropriately. All right. And then typically our symptoms, we're going to have that liver failure, sure, but we're also going to have these tremors and behavioral changes. So this is going to be like a 17, 18-year-old boy who's coming in with psych symptoms and tremors, and you're going to be like, okay, maybe do they have some sort of issues with a medication they're taking? What are they taking, SSRIs or something? Do they have some sort of antipsychotic that's causing issues? And then you'll notice that they have Kaiser-Fleischer rings, and you'll put everything together and be like, oh, this is Wilson's, right? Okay. Let's move on to 15. Give me a half second to cough real quick. Everyone at home, I'm very sorry because you can still hear this. All right. Thank you. I had to dive here for a half second. Cool. Let's move on to 15. We have a 52-year-old that presents with diabetes, skin hyperpigmentation, and arthralgias. Labs show elevated ferritin and transferritin. What is the underlying pathophysiology? I should probably stop talking during some of these questions because I may be causing issues with answering further questions, right? So in this case, diabetes, skin hyperpigmentation, arthralgias, this is going to be a very weird one in terms of why you have all these issues. Hypogonadism is potentially also one of the things you're going to see. This is hemochromatosis now. I know it feels like it probably should have nothing to do with diabetes, hyperpigmentation, and arthralgias, but when you have too much iron deposition throughout the body, this is what's going to happen. The issue is that we have decreased hepcidin formation. And why is this an issue? Well, when we have decreased hepcidin formation, we're going to have increased iron absorption in our intestines. Not iron. Sorry. Iron absorption in our intestines. All right, and then we're also going to have deposition of iron in all our tissues, liver, etc. Liver being the biggest thing that'll be affected, but pancreas, heart, skin. That's why you you can have cardiomegaly when you have hemochromatosis, all that kind of stuff. But decreased hepcidin formation is going to be the main mechanism for why we have issues, because we have an HFE mutation. That's typically what the hemochromatosis mutation is. That's going to result in decreased hepcidin. All right. It's typically called bronze diabetes. It's because they get hyperpigmentation. Let's move on to 16. We have a newborn that develops prolonged jaundice. Liver biopsy shows PAS positive globules and hepatocytes. Which protein abnormality is responsible? So whenever we're thinking of PAS positive, right, globules that are going to be found in hepatocytes, and we have liver dysfunction, we probably have one of these issues with our alpha-1 antitrypsin. Because in these patients, you're going to have something like neonatal hepatitis, cirrhosis, or panacenar emphysema is what they'll say when you start having that lung and everything going on. So when that happens, when we have this specific positive globules of PAS in hepatocytes, and it's such a young patient, it's always going to be alpha-1 antitrypsin. All right. It's going to be a misfolded alpha-1 antitrypsin, and that's the mechanism of what's going on. When you have that, then you're going to have issues trying to prevent breakdown from things like collagenase, elastase, that kind of thing. Those kinds of enzymes are just going to wreak havoc everywhere in the body, including the liver, and then you're going to start having issues in the lungs. All right. Okay, let's move on to 38, or sorry, 37, which is 17 in this case. We have a 55-year-old woman that presents with episodic flushing and diarrhea. CT scan shows a small bowel mass with liver mets. Which substance is most responsible for her symptoms? And then I could probably add the question after that is, why did it wait until there was liver mets for the patient to have symptoms? So whenever someone has these kinds of tumors that secrete a lot of these catecholamines or neurotransmitters, depending on what is being secreted, it just depends on where that tumor is as to whether or not you'll get symptoms. The problem is that certain of these things are broken down by the liver. So remember, I said there's first pass metabolism. Anything that's in our colon, which we now have a small bowel mass, so that's something in our small bowel that's going to go through the liver first. Our liver will break down whatever neurotransmitter catecholamine might be sent out by this colon tumor, depending on what it is. So if we have episodic flushing and diarrhea, this sounds like something like a carcinoid syndrome where we have serotonin being released. But why is it that this patient doesn't have any issues until there's a liver metastasis? It's because serotonin is broken down by the liver. So if this is only a colon tumor, you won't actually know that you have high serotonin until you do some sort of maybe biopsy of the liver, or you actually tested the blood, but people aren't going to actually do these kinds of things because you won't have symptoms. You won't know. But suddenly, you'll have high serotonin levels once it actually metastasizes to the liver, because the liver is the only thing breaking down serotonin. Maybe there's some small amount of breakdown in the lungs, but not enough to keep up with anything. So that's when you start getting the right-sided valve issues, because suddenly once it metastasizes to the liver, you're going to have high serotonin levels. The right side of the heart is going to be mainly affected, and then the lungs will kind of break down some of the serotonin as well, but not nearly as much as the liver can. All right, so in this case, serotonin is the reason why we have this carcinoid syndrome going on. Okay. And you'll have that trifecta. Okay. Let's move on to 18. We have a 2-year-old boy that presents with painless rectal bleeding. Technetium-99 scan shows uptake in the distal ileum, which embryologic structure failed to regress. So whenever we see a patient have a technetium-99 scan and it has a positive result in the distal ileum or something like that, and they have this painless rectal bleeding, this is going to be Meckel's diverticulum. And you're probably wondering, what does Meckel's diverticulum have to do with anything? Why is it in the distal ileum? What is Meckel's diverticulum? This is when a specific structure doesn't go away, and that specific structure has potentially some activity in terms of gastric acid secretion or that kind of thing, and it's going to cause some bleeding in our stool in the long term for these children. And it can also be a branch point in terms of causing something like intussusception or something. So whenever we have Meckel's diverticulum, we need to remove that patent duct and remove it so that we don't have any further issues. A technetium 99 scan will help find it. What is the actual structure that remains? It's a vitelline duct. All right. This vitelline duct is typically going to be connected to the distal ileum, and you're going to have some gastric acid secretion in that distal ileum, which is why you're having such bad bleeding and ulceration, that kind of thing, in that area. And that's why they're going to have blood in their stool. All right. And typically you're going to live by the rules of 2% of the population. So relatively common for all things considered, right? Not most of these diseases don't necessarily have that big of a population risk, so relatively common. 2 inches long, and it's going to be 2 feet from the ileocecal valve, so terminal ileum for the most part, 2 feet from it. And remember, we have like dozens and dozens of feet of intestines in general, so 2 feet from the ileocecal valve is nothing. All right. This is typically what it looks like here. All right, let's move on to 19. We have a full-term newborn that fails to pass meconium within 48 hours. Abdomen is distended. Rectal biopsy shows absence of ganglion cells in the distal colon. Which embryologic process failed? So what is the diagnosis? And then we'll talk about what that diagnosis means. So when you fail to pass meconium in the first 48 hours, that means you didn't actually have a stool. Meconium is that first stool that looks nothing like normal stool. It's like this weird yellowy substance. And it's kind of just what was in your colon before you actually were born and started eating. So when we have that meconium, that means, okay, we've officially had our first poop, our first stool. Now the rest of it should be milk related. When you drink milk a lot, you should be having this weird, like small, yellow, grainy stool, and not like a normal brown stool that people really think about. Brown stool comes when you eat more food, different types of food, not really when you're just drinking milk. So in this case, if we have absence of ganglion cells and we're not passing meconium, this is most likely Hirschsprung disease. Right? And what is Hirschsprung? That's when people think of like the squirt sign or that kind of thing. It's that we don't have the ability to actually relax our external sphincter and allow for stool to pass from the inside of our body to the outside of our body. What is allowing that to happen? Well, we need ganglion cells, which means nerves at that end that aren't making it there. What are nerves? Or where do they come from in terms of embryology? They're neurocrest cell, right? So if we don't have nerves that are allowing relaxation down there, it's a neurocrest cell migration failure, and that's why we're having issues. All right. Typically, the way they'll ask this question is like, they'll say that it's Hirschsprung disease in terms of the symptoms, and they won't tell you there's an absence of ganglion cells. They'll just ask what didn't happen, and it's usually neurocrest cell migration or something like that. Okay. And the squirt sign, that's the explosive stool after rectal exam. So as a doctor goes to put in their finger to see if the anus is patent, because you could have imperforate anus, which means you just don't have an anus that's patent, or if there is an anus, it might not be connected to the terminal rectum, right? And so when you go to put your finger in, you'll notice that there's poop that comes projectile flying out, and that means it's probably Hirschsprung disease and they have squirt sign, okay? If nothing comes out, then they may have imperforate anus, and in which case you're going to have to do surgery. All right, let's move on to 20. This is the last one of our GI section, then we'll move on to neuro. We have a 65-year-old man presents with early satiety and weight loss. Endoscopy reveals an ulcerated mass along the lesser curvature of the stomach. Biopsy shows signet ring cells. Which factor most likely predisposed him to this malignancy? So whenever we think of signet ring cells, we're thinking of this very specific cancer, right, that we would consider probably related to H. pylori infection, right? Whenever we're thinking of H. pylori infection, H. pylori is going to put us at risk of things like malt lymphoma, right? And whenever we have that, we can have the signet ring cells, the Linitis plastica, I believe. But for the most part, these signet ring cells mean we have a chronic H. pylori and it's causing gastric adenocarcinoma as well. And that's what we have here. Malt lymphoma is going to be more of the intestinal side when we have the small intestine. And then I cannot spell no, I did spell adenocarcinoma. I can spell. Gastric adenocarcinoma is what H. pylori can cause when we have the signet ring cells. All right. Anytime you see signet ring cells, gastric adenocarcinoma, and it's probably some sort of H. pylori in this case. All right. Okay. Now we're moving on to our neuro section. All right. Question number 1. We have a 72-year-old man with AFib that suddenly develops right-sided facial droop, right arm weakness, and expressive aphasia. Sensation is decreased on the right side of the face and arm. Which vessel is most likely occluded? So when we're thinking of strokes and we're trying to rule out if something is a stroke or not a stroke, we're trying to figure out which symptoms match more of a stroke and which symptoms might match something more of a Bell palsy or something, right? Why is this something that we would be considering an emergency, and why aren't we saying it's something like a Bell palsy if we just had the face and not actually the arms or anything? How do we differentiate Bell palsy from stroke? Bell palsy or Bell's palsy? I don't. Bell's palsy. One S. One O. There you go. We have upper forehead sparing. Because there's cross innervation coming from the other side, there's decussation beforehand. And so with that cross innervation, whenever we have a Bell's palsy, typically it's considered the motor neuron aspect and not the cranial nerve side. And that's what's allowing us, it's the lower motor neuron side. That's what's allowing us to have the sparing of the upper forehead. A true stroke, in Bell's palsy would not have sparing because it's the lower motor neuron side. I apologize. I will backtrack for 2 seconds. In Bell's palsy, you will not have sparing of the forehead because the decussation has already happened. In a stroke, which is the upper motor neuron sign, you would have sparing of the upper forehead because it's considered decussation is happening after. And so, if anything, you would have issues with the opposite side of the face in terms of the upper forehead, not necessarily the same side of the face. So in a stroke, you're not going to have the same symptoms as you would with a Bell's palsy, where in a Bell's palsy, you would have issues with the forehead. But let's go back to this question. In this sense, we have right-sided facial droop, right arm weakness, expressive aphasia. We officially have a lot of different things going on. And this expressive aphasia is probably going to match something like a Broca's area, right? Because we can't actually express ourselves. So Broca's area is affected. And then we also have decreased sensation to the face and arm, not only this weakness on the right side. This is likely a very large vessel. This is probably some sort of MCA territory, right? Basilar is going to be something more of like when we have a medial pontine issue, not something like this. So in this case, we're probably considering some sort of middle cerebral territory. So now it's a matter of trying to figure out if this is a right or left middle cerebral. Well, what's happening in terms of our motor side, right-sided left versus left-sided, when it's in the brain? If we have our brain up here, this is a lovely brain. You guys are probably saying I'm Picasso or something at home. No smooth brains here. All right, so in this case, when we have our nerves coming out, these nerves are going to decussate and then go down to the opposite sides for our motor neurons. So in this case, if we have issues with our right side or left side? Let me check. On our right side, then this is going to be a left-sided brain lesion. And that's going to cause issues on the right side of our body. So in this case, this is going to be a left middle cerebral artery that's affected, and that's why we're having all these symptoms from our Broca's area, right? Because Broca's area is typically going to be, if you kind of pointed right where your temple is, that's typically going to be right where your Broca's area is. It's technically anterior from the temporal lobe, but it's going to be mainly in that area. Aside from that, if you're thinking of some of these other strokes, posterior, right anterior would have legs that are more involved, not the arm and face, right? Because the other side of it is that if we think of where things are located in our brain, so if we have a cutout of our brain, this is kind of like a slice, the further to the sides you go, then this goes legs, arms, face, right? And ACA will control this wedge here. So if you have an anterior, then cerebral artery, then that would cause leg issues. MCA will do both of the sides. All right. So in this case, we're expecting this to be some sort of MCA stroke because we have our arms and face affected. Okay. Perfect. And if we're thinking PCA, that's typically going to be our vision, but it's going to spare the macula typically because the macula has cross supply, typically from the MCA. Okay. Let's going to move on to number 2. We have a 65-year-old man with long-standing hypertension that develops pure motor hemiparesis affecting the right arm, face, leg. There are no cortical signs. Cortical signs would be things like aphasia, neglect. Which structure is most likely affected? So when we have chronic hypertension, we're going to have a lot of our smaller structures, like our basal structures, are going to be at risk. Okay. But then when we have specifically a pure motor deficit, this is going to be very specific type of stroke, a very specific type of stroke. It's going to be the left internal capsule. All right. Whenever we have an internal capsule stroke, we're going to have basically purely motor. All right. If we're thinking of some of these other strokes, a thalamic stroke is going to be sensory. So that's when they have like the thalamic pain syndrome, right? Precentral gyrus, that's going to be the motor of that side, but it's not going to potentially just be motor. There might be some other things involved, right? If we're thinking of cerebellum, we might have some ataxia involved, right? So this is going to be matching just a left internal capsule. This is pretty high yield because they'll ask this type of question. Typically, it's a lacunar infarct. Remember I was saying the smaller structures, lacunar infarcts are when you're having issues with your lenticular striate arteries. No, lenticulostriate. There we go. And it's because you have typically hyalinization of these arteries, and then you have some sort of rupture. That's what's going to happen. Okay. Let's move on to 3. We have a 59-year-old woman who develops sudden vertigo, dysphagia, hoarseness, and ipsilateral facial pain loss, contralateral body pain loss, and ipsilateral Horner syndrome. Which artery is most likely occluded? So in this case, we have some very specific symptoms where we have an ipsilateral Horner syndrome. That means we don't have any sympathetic innervation on that side of the face. Or not on that's like the mydriasis, anhidrosis, that kind of thing, right? Ptosis. We have ipsilateral facial pain loss, right? Because pain loss in the face is going to be traveling with the same Horner syndrome issues that we're going to have. But we have contralateral body pain loss, right? Anything that's sensory is typically going to be a lateral structure. So whenever we're thinking of our midbrain, pons, medulla, right? Midbrain, pons, medulla. And then we're thinking of what structures are involved and whether it's medial or lateral. Let's talk about the cranial nerves, and then we'll talk about most of like what else is going on. Midbrain is going to be our 3 and 4 that are coming out, and it's going to be medial. Why? This is like the rule of 12, where if it goes into 12, then it's going to be medial. If it doesn't go into 12, it's going to be lateral. So 3 and 4 are going to be medial. If we're thinking of our pons, that's where 5, 6, 7, 8 will come out. So 1, 2, 3, 4 come out above, 5, 6, 7, 8 in pons. And we're going to have 6 as the only medial one. We're going to have 5, 7, and 8 over here. And then in terms of our medulla, only 12 will be medial. And then we have 9, 10, and we have an honorary guest of 11. The accessory nerve is kind of weird. Doesn't actually have anything to do with the brain, technically. Goes to like the sternocleidomastoid and the traps, but that's fine. It's like an honorary guest. So in this case, beyond that, we're also going to have motor and sensory. For the most part, motor structures are going to travel medially. And then sensory structures. This is going to be weird. Sensory structures are going to travel laterally. So if we're having both a combination of sensory and something that'll give us some sort of, okay, this is definitely pons or medulla, then we'll be able to tell what this is. Let's talk about which arteries there are as well, because we can't just say what should be there, we should also say what artery would be affected. So midbrain is going to be both PCA. PCA is going to do both sides. All right. If we're thinking pons, we're going to have our basilar as our medial side, and then we're going to have our ACA, right? Anterior inferior cerebral artery. And then if we're thinking of medial medulla, this is going to be our vertebral artery or anterior spinal, either one. It just depends. Anatomy can vary between people. And then our lateral is going to be our pica. It's going to be posterior inferior. I like to try to remember it as posterior coming after or later than AICA, just because P comes after A. So I remember it as lateral pons is going to be our anterior, and then lateral medulla is going to be posterior. All right. So in this case, if we're trying to match our dysphagia, our hoarseness, our vertigo, which cranial nerves are those, right? Well, vertigo, that's technically cranial nerve 8. But remember, when we have the vestibulocochlear nerve, right, the top part is going to come out in the pons. The bottom part is going to come out in the medulla. And the bottom part is what's going to control our vertigo symptoms, right? Dysphagia and hoarseness have to do with cranial nerves 9 and 10. And then when we're losing our face pain, body pain, the ipsilateral is because when we're this high up, we don't have decussation of these nerves. Decussation of the body nerves is happening lower down, right? Because decussation of our body nerves are going to happen at the spinal level, right? Depending on if it's pain or temperature, that kind of thing. Whereas decussation of things like our proprioception is going to happen when we hit the medulla. But in the face, those do not decussate yet. So this is why we're having a pica stroke, a posterior inferior, because this is what we would call lateral medulla. Or I believe it's like a Wallenberg stroke. Sometimes they'll call it that kind of thing. Yeah, Wallenberg syndrome. There we go. But it's a lateral medullary stroke. It's a pica occlusion. The nucleus ambiguans, that's where we're having the dysphagia hoarseness. That's cranial nerve 9. And then the spinal trigeminal tract, that's where you have the spinal thalamic, sympathetics, all these S's, right? The M's and S's, motor versus sensory. That's why you're having the midline versus the lateral structures that are going to be affected. All right. Perfect. Let's move on to 4. We have a 30-year-old man who suffers a stab wound to the right side of his spinal cord at T10. He develops a right-sided loss of vibration and proprioception below T10 and left-sided loss of pain and temperature below T12. What is the diagnosis? Well, anytime you have this weird loss of one thing on one side, one thing on the other side, it's only ever one thing. It's always going to be Brown-Séquard syndrome, but we can talk about why you're getting Brown-Séquard syndrome. So this is going to be kind of our spinal cord, right? Cool. And then we have our little syrinx in the middle. So when we have a stab wound, and I'll kind of draw like a primordial little knife, and it's coming into our spinal cord and it's cutting off this side of the spinal cord, we have right-sided loss. Yeah, good. This is going to work out perfectly. So we are at T10 where this injury happens. So we are going to lose every nerve that's at this level, but we're also going to lose potentially stuff that's on the other side. But why aren't we having left-sided pain loss at T10? Well, technically, when we have our crossing, our decussation of pain and temperature, it's actually traveling in the dorsal column first for a little while, or dorsolateral column. It travels there first for like 2 levels, then it decussates. And where is it decussating, right? The anterior commissure is where our pain and temperature is going to decussate. So at this point, we're going to lose all of our pain and temperature just at T10, but we're not going to lose it below T10 on this side. We'll lose a T12 and below on the other side. And it's just because it's decussating about 2 levels after. So it's coming from this back area, it'll decussate in the front, and then now you'll have officially our T12 and lower is going to be coming up that way. All right, but this is Brown-Séquard syndrome. Typically, you'll have motor and proprioception down on the same side. And then you'll have pain and temp on the opposite. Contralateral. All right. Cool. Let's move on to, and this is kind of like a good representation of what's going on. Let's move on to 5. We have a 68-year-old man that presents with a resting tremor, bradykinesia, rigidity, and masked facies, which brain structure is primarily degenerated. So this is a very specific set of symptoms that we're kind of expecting. Whenever someone has bradykinesia and then they have this rigidity, tremor, masked facies, but they're saying resting tremor, right? And it gets better when they move, or else that'd be essential tremor as well, or intention tremor. Essential is just all the time. Intention is when they're actually trying to do something, then they have a tremor. Resting tremor that gets better, this is Parkinson's. Okay. And if it's not Parkinson's, then it's one of the Parkinson's-like diseases, Parkinson's plus, or even something like Lewy body dementia. Late-stage Lewy body dementia is going to be Parkinson's, right? Parkinson's starts with the motor side and then goes to the psych side eventually. Lewy body dementia starts with the psych side. So that's where you're having the hallucinations, the memory loss, and then eventually you can have the tremors and that kind of thing. I actually just had a grandfather pass away this year who had Lewy body dementia, and at the end he was having the pill rolling tremors, that kind of thing. So it was interesting seeing this kind of thing in a personal side from your family side. But for the most part, Parkinson's will start with these symptoms. Lewy body dementia will start with the opposite side. So if we're thinking of Parkinson's, what is the main structure that's affected? It's the substantia nigra, and we're not able to make any dopamine anymore. And that's what's the issue here. Lewy body dementia is also an issue, but that's the alpha-synuclein. So alpha-synuclein's on both of them. But we're just going to have decreased dopamine production. And that's the main issue that we have here. All right, in Parkinson's. Okay, let's move on to question 6. We have a 42-year-old woman who develops involuntary choreiform movements and progressive cognitive decline. Her father had similar symptoms. Which structure is primarily affected? So whenever we have a person coming in and they have issues where they have these random movements, choreiform, if you guys remember Sydenham chorea, which is when you have the rheumatic fever, and the Jones criteria, when you have strep, right? In this case, you'll have the Sydenham chorea, which is like random movements. The kid can't control it anymore. This is basically the same exact thing that's happening in adults. So Huntington disease will have a very similar appearance where you have the chorea, where you're just like random movements, and they'll try to hide it. Patients will often say like, oh yeah, I meant to do, I was just trying to reach for my head. Because when they have that random fling of the arm, they'll try to then cover it by like brushing their hair or something and acting like they meant to do it. But it's because they're trying to hide the fact that they have these random movements they can't control. And then aside from that, the cognitive decline, this is what's happening in Huntington's disease. This is when you have the CAG repeats, typically more than 120 times is going to give you Huntington's disease. And where are we having the breakdown? This is the caudate nucleus. All right, Huntington's disease, if you can remember, caudate nucleus is what's being broken down. And for the most part, you also have the anticipatory phenomenon. So if dad had the disease at 40 and then he had more trinucleotide repeats in his offspring, then the child, maybe the daughter, will have the disease at 35 or 30. Just because the more trinucleotide repeats you have, the worse off it's going to be. Okay. Let's move on to number 7. We have a 28-year-old woman who develops blurred vision and weakness that improves over weeks. MRI shows periventricular plaques. Which pathologic finding is expected? So whenever someone has a issue with blurred vision and weakness, and it's a relatively young woman, your mind should automatically go to MS, something like multiple sclerosis. All right, we should always be thinking of that in our differential, regardless of what's happening, because MS can cause a lot of different things. But blurred vision and weakness are sometimes the very first symptoms you'll see in someone who has MS. What is MS? MS is a central nervous system demyelination. Demyelination. And you're probably wondering, well, why is it only central nervous system? What about peripheral nervous system? Peripheral nervous system demyelination is going to be Guillain-Barré syndrome. So typically, MS is going to affect things only in our central nervous system, and that's when you're going to have the illegal clonal bands, that kind of thing. And one of the very most common first things you'll see on CTs or MRIs is going to be periventricular plaques. Okay. And the first symptoms they'll often present with is optic neuritis. Just because optic nerve, that's a CNS nerve, right? Optic neuritis is going to be one of the first things you'll see. That's when they have that like green-red color dissociation. They have like color blindness all of a sudden. All right. And again, this is going to be demyelination of central nervous system, which is oligodendrocyte destruction. All right. Don't get tricked by the demyelination of peripheral nerves. That's Guillain-Barré syndrome. Okay. And then anterior horn cell degeneration, that's ALS, beta amyloid deposition, they're going to have Alzheimer's. Okay, let's move on to 8. We have a 24-year-old woman, develops fluctuating ptosis and diplopia that worsens throughout the day. Adrophonium improves symptoms. What is the underlying mechanism? So whenever someone has ptosis and diplopia that worsens, things that worsen throughout the day, and then suddenly this weird medication, edrophonium, what even is that, right? Edrophonium makes it better. This is going to be something like myasthenia gravis, right? Myasthenia gravis is when we have an acetylcholine receptor antibody, right? So a postsynaptic acetylcholine receptor antibody is causing us to have issues with our muscular junction where we can't actually use our muscles, right? And so in this case, when we try to use our muscles, with time, we're going to have an issue where it gets worse throughout the day because our receptors are kind of being affected more and more, and we're going to have less receptors available to actually activate that muscle. And so with time, we're going to run out of acetylcholine, that acetylcholine receptors ready to be activated, so acetylcholine ready to use, and so it's going to feel like we're very fatigued. We're going to have ptosis, diplopia throughout the day. Edrophonium helps because now we're having increased acetylcholine activation where possible, right? Because edrophonium is going to be that quick fix, and if they respond to it, then that's myasthenia gravis is confirmed. And which one of these answer choices is going to match what's happening? Well, I just said acetylcholine receptor antibodies. It's going to be against the postsynaptic acetylcholine receptors. And you're probably wondering, the calcium channel, that's Lambert-Eaton. Okay. Decreased acetylcholine release, that's botulinum, right? And then degeneration of anterior horn, ALS again. Demyelination of motor nerves, that's potentially going to be something like Guillain-Barré syndrome, although Guillain-Barré syndrome will also have issues with sensory nerves as well. All right, let's move on to 9. We have a 60-year-old smoker who presents with proximal muscle weakness that improves with repeated use. He has dry mouth and impotence. Which mechanism is responsible? So now we have basically the exact opposite, right? With use, it gets better. This is the exact opposite. Everyone kind of remembers Lambert-Eaton gets better with use. Myasthenia gravis gets worse with use. So which one of these issues is happening when we think of something like a Lambert-Eaton? This is a presynaptic calcium channel antibody, right? Again, if we're considering our receptor, let's kind of draw out our receptor real quick, just so everyone kind of remembers what's going on with Lambert-Eaton and then myasthenia gravis. So here's our terminal neuron. These are our little vesicles that have acetylcholine in them. Here are our calcium receptors that are going to allow calcium in. We need calcium to influx in order for us to release acetylcholine. And then let's draw our muscle receptor. We're going to have these acetylcholine receptors here that'll actually activate the muscle. When we have Lambert-Eaton, with Lambert-Eaton syndrome, these calcium receptors are going to be blocked off. And I will draw a couple more just to kind of show that not every single one is going to be blocked off. So some of them will be blocked off, and you'll have one of them that might still be open, right? Because the antibodies aren't going to be perfect. They're not going to get every single one. So this one area is where calcium is going to be able to influx. As you try to activate your muscle, calcium will start going in. As you try to do more calcium will go in, and more calcium will go in. And with time, with more calcium being brought in, more and more acetylcholine will eventually be able to make it out and make it to the receptor. So with time, time equals muscle strength for Lambert-Eaton, equals more muscle activation. Because with time, more calcium can make it in through that one receptor, and eventually it'll overcome the fact that only one receptor was available and all the other ones were knocked out. Okay? When we're thinking of something like myasthenia gravis, where we have the same exact, I'll kind of just try to make this one match exactly what's going on. And then now we have our calcium channels and our acetylcholine. What's happening here is that we have normal release of acetylcholine. Calcium can make it in on both sides like normal. Acetylcholine can make it out like normal. But now we have an antibody against this receptor. And what's happening here is that the acetylcholine can only activate this one receptor. So we only have one receptor available for acetylcholine activation. With time, if that one receptor is going to be activated, acetylcholine esterase will start to break it down. That's it. We only have the one receptor available. We don't have all the other receptors available. So with extended muscle activation, it's going to get worse because we don't have increased activation of the muscle from more acetylcholine receptors. So it's going to have the opposite effect where with more muscle use, it's going to get worse. So typically with myasthenia gravis, your best muscle use is going to happen in that first moment, and then it's going to get softer with time, weaker with time. Lambert-Eaton, you're going to try to flex very hard at the beginning and you can't, and then with more time, you'll actually be able to flex all the way. All right. So that's the main difference of what's going on between the two. All right. Let's move on to 10. We have a 35-year-old man that develops ascending weakness 2 weeks after a diarrheal illness. Reflexes are absent. CSF shows elevated protein to normal cell count. What is the final diagnosis? So this is now where we have peripheral nervous system demyelination, right? And you're probably wondering how I know that this is Guillain-Barré syndrome. Well, it's because it came after diarrheal illness. Campylobacter is very commonly going to cause Guillain-Barré syndrome. And so if you have a diarrheal illness recently and now you have some sort of issue with reflexes, maybe even some sensory issues, and then you have this elevated protein in the CSF, where you're going to have the albuminocytologic dissociation, that's going to be Guillain-Barré syndrome. All right, every single time. Albuminocytologic dissociation. Boom. And this is a favorite as well. For some reason, they love testing Guillain-Barré syndrome, Lambert-Eaton syndrome, myasthenia gravis. While I was on rotations, I only ever saw one patient with myasthenia gravis. I did not see any with Lambert-Eaton syndrome, and I only saw one with Guillain-Barré syndrome. And this was across all the different specialties because technically speaking, when you're on medicine, some of these patients might be on your floor. Our neuro ICU at our hospital only has enough space for the patients who come in with really bad strokes or with really bad conditions like CJD, right? Mad cow disease, as they'll call it colloquially. We don't have space for some of the patients who have just generic like myasthenia gravis, so they'll go onto the normal medicine floor. So even throughout my entire year, only seeing 2 patients total with those 3 different conditions, they're not very common, but for the most part, they love to test them anyways. All right, let's move on to 11. We have a 58-year-old man that presents with progressive muscle weakness, muscle atrophy, fasciculations, hyperreflexia, positive Babinski sign, sensation is intact. Which structure is most affected? So let's talk about these different symptoms, right? Muscle weakness, muscle atrophy. Muscle atrophy is a lower motor neuron sign. Hyperreflexia, that's an upper motor neuron sign. Positive Babinski sign, that's an upper motor neuron sign. Fasciculation, wait a second. Why do we have a mix between upper motor neuron and lower motor neuron signs? It's because we're having degeneration of our anterior horn cells, all right? When we have degeneration of our anterior horn cells, which is something like ALS, we are destroying the motor neurons at that level and below. So the ones that are below are going to have an upper motor neuron sign. The ones at that level will have a lower motor neuron sign. And typically one of the first things you'll see with something like ALS is you'll have tongue fasciculations. That's one of the first symptoms that you'll see, as well as arm weakness. Arm weakness and fasciculation in the arms as well as one of the first things you'll see as well. All right. But again, ALS, anterior horn, That's where you have all your motor neurons. That's going to mean that you have upper and lower motor neuron signs at the same time. And then you're probably wondering, well, what happens if you have, let me go back. What happens if you have a baby form of ALS? Baby ALS is spinal muscular atrophy. So if you have a baby coming in with fasciculations and all that, and it basically looks like a baby form of ALS, baby ALS is going to be spinal muscular atrophy. All right. Okay, let's move on to 12. We have a 74-year-old woman that presents with progressive memory loss, difficulty performing daily activities. MRI has cortical atrophy. Which histologic finding is most characteristic? So with this type of memory loss, performing issues with performing daily activities, and then cortical atrophy, this is just kind of what we have with time, right? With time, we kind of lose our memory and issues with daily performing activities, but it starts to look like Alzheimer's disease, right? Everyone kind of looks like they have Alzheimer's disease by the end of it, but with the cortical atrophy, this is Alzheimer's disease. We're going to have beta amyloid plaques as our main thing, right? Lewy bodies, that's Lewy body dementia. Caudate degeneration, we just said that was Huntington's disease. Pick bodies, if we're talking about pick bodies, we're probably talking about Niemann-Pick, if anything. And then oligodendrocyte destruction, that's MS. We just talked about that earlier. All right, but again, beta amyloid plaques, Alzheimer's disease, we're going to have the memory loss, an issue with performing things like at first it'll be things that are like a little more complicated, like doing our bills and things like that. Eventually it'll be shopping, eventually it'll be cooking for ourselves, eventually it'll be like grooming ourselves, right? We won't be able to shower ourselves, things like that. All right, okay, let's continue on to 13, down to our final push. We have a 45-year-old man with chronic alcoholism that presents with confusion, ataxia, and ophthalmoplegia. Which brain structure is most likely affected? So when you have this chronic alcoholism, and then now you have these symptoms, I always remember this as BACON. Although there's other acronyms, I know Anki and Sketchy and all these things have acronyms nowadays. But in this case, this acronym B1 is going to be thiamine. A is going to be ataxia. C is confusion. O is ophthalmoplegia. And then N is going to be nystagmus. And what is this referring to? This is going to be Wernicke's encephalopathy. So whenever someone has chronic alcoholism, they're going to be at risk of being deficient in B1. That's why I include B in mine for bacon. And whenever we have these issues, we're going to also have potentially issues with ischemia. When we have issues with ischemia, things like Wernicke's encephalopathy, what's going to be most at risk is the things that are most at risk of ischemia in general, something like the mammillary bodies. All right. And that's just because in patients who have chronic alcoholism, they have less nutrients than normal, less glucose. Things that are usually at risk of ischemia, like the mammillary bodies, are probably also going to be at risk for something like a thiamine deficiency. Why? In thiamine deficiency, typically, again, we're trying to produce more NAD+, because typically when we break down alcohol, we're going to get a lot of NADH. We need to regenerate NAD+ to continue breaking down glucose. We can't if we have a ton of NADH and then no thiamine. Thiamine is needed to regenerate NAD+. And in that sense, we can't break down more glucose, so we're going to have a buildup of now we're technically energy rich because we have all this alcohol we broke down, but then our body's like, wait a second, I have no energy. So you're going to become acidotic sometimes. And then if you give them glucose before thiamine, you'll just make the problem worse. All right. Okay. Let's move on to 14. Any questions so far? I also realized I did a bunch of questions without asking if there are any questions. We're down to like our last 6 or 7 questions. 6, 7, you know. All right, cool. Let's move on to 14. We have a 29-year-old woman who develops bilateral loss of pain and temperature sensation over her shoulders and arms. Vibration and proprioception are intact. What is the most likely diagnosis? So, in this case, when we have bilateral loss of pain and temperature, but not anything else, we have some sort of anterior structure issue. But why is it specifically something like pain and temperature, not motor, right? So when we look at our spinal cord, typically, and then let's put our little syrinx there. Typically, the posterior side is going to be proprioception, vibration, And then the anterior side is going to have motor. And then we're also going to have pain and temperature, right? So in this case, we've lost just pain and temperature, but not motor. Why didn't we lose motor? Well, remember earlier I was saying pain and temperature are going to decussate at this anterior commissure. That means they're crossing over right here. If we had something that was very close to that structure that put some pressure on it, maybe an increasing in size syrinx from someone who has syringomyelia, then we would have an issue with just pain and temperature, but not motor. Eventually, if it gets really, really big, then motor will also be affected. But that's why you'll have a cape-like distribution. They'll call it cape-like, because it's only affecting really the shoulders and upper back of pain and temperature. And eventually you can have weakness and things like that as well. As it keeps increasing in size, you'll have motor issues. But for the most part, pain and temperature is where syringomyelia will start. Okay? And then let's move on to 15. We have a 50-year-old woman that develops sudden worst headache of her life. CT shows blood in the subarachnoid space. What is the most common cause? So when we're thinking of our different injuries in terms of bleeds, right, that kind of thing, let's talk about where the bleeds are coming from. Because we have epidurals in terms of hematomas. We have subdural. And then we have subarachnoid. And then what are our common causes of them? All right. Epidural, this is middle meningeal artery. Okay. Subdural, these are the bridging veins. Subdural is typically some sort of shear that causes the bridging veins to kind of tear. It can be in bad trauma in a younger person or in very light trauma in an elderly patient, right? With time, you're not going to have vessels that are very pliable. So literally just because you sneezed, maybe you'll cause some sort of subdural. Epidural, middle meningeal artery, that's typically that you hit yourself right in the temple area and you cause a rupture of that middle meningeal artery. Subarachnoid, that's typically going to be something like a berry aneurysm that causes bleeding into the subarachnoid space. All right, so typically we're going to have some sort of rupture of a berry aneurysm. That's the most common cause of something like a subarachnoid bleed. Okay, and oftentimes it's going to be at the circle of Willis branch point. And we know it's a subarachnoid because it's the worst headache of their life. They don't even need to tell us that it's a subarachnoid space. Whenever they say worst headache of their life, subarachnoid hemorrhage. All right. Okay, let's keep going on to 16. We have a 17-year-old boy who's struck in the head during a football game, loses conscious briefly, then regains it, then deteriorates rapidly. CT shows a biconvex hyperdensity, which vessel was likely injured. So when we're thinking of a biconvex hyperdensity, that's something that looks like a lens shape instead of a crescent shape. Right? Lens, crescent. And these are the two different types of bleeds that we would see for an epidural and a subdural. Why do we see two different patterns? This is based off of whether or not there are suture lines preventing blood from moving to the next area. All right, there's a suture here and a suture here. And epidural bleeds, we're preventing blood from spreading into the next space. Suture lines might be in these areas, and subdural bleed, they can cross the suture lines. They don't have to worry about suture lines. Then you're probably wondering, what about subarachnoid bleeds? Subarachnoid hemorrhage will have the starfish sign, and it's going to have a very different representation because it's not going to have a normal bleed pattern like these will. It'll just be in spaces where you'll have CSF. So the ventricles might show that you have a bleed in a subarachnoid hemorrhage, but not like these. All right. And then this is also classic for an epidural bleed as well, where you lose conscious briefly, then you're fine for a little while, and then eventually you lose conscious completely and probably go into a coma. And if you're not intubated quickly and they try to treat you quickly, you can die. All right. But again, epidurals, that's going to be middle meningeal artery. All right. And this is what we mean by that biconvex. It's the lens shape on the CT. Okay. All right. And this wouldn't be something you guys need to know, but whenever you're thinking of some sort of stroke, bleed, etc., non-con CT is what you need. Okay. Let's move on to 17. We have an elderly man that falls and develops gradual confusion over weeks. CT shows a crescent-shaped hyperdensity crossing suture lines. What is the most likely cause? Lo and behold, I just explained this in the last cause. Whenever we think of subdural bleeds, it's going to be a bridging vein rupture. When he fell, right? He fell and had gradual confusion. It's that he probably had a small tear in the bridging vein. Over time, that space kept filling with blood, and that's why he has gradual issues with confusion. And subdurals can be pretty chronic. So sometimes patients will come in like a month after the initial injury and won't even remember. And then you'll see, oh, you have a subdural bleed. Did you have recent trauma? And they'll be like, oh, yeah, like a month ago, I was in a car accident or something. And they'll be like, oh, that's probably what happened. All right. And these can cross suture lines again, right? And this is why it looks more of a crescent shape. So it'll look more of like a moon, right? The DreamWorks moon, right? Or as Gru would say, we're stealing the moon, right? The moon. All right. Move on to 18. It's a late night. Okay. 18. We have a 48-year-old woman who presents with sudden diplopia and ptosis. Exam shows a down and out pupil with down and out eye with dilated pupil. Which lesion is most likely? So we have an eye that's down and out and dilated. Whenever we have an issue with a dilated pupil, that means we don't have any parasympathetic innervation, right? Sympathetic innervation causes dilation of pupils. Parasympathetic causes constriction of pupils, right? Whenever we have a down and out pupil, that likely represents that we don't have any of our normal eye muscles that are controlled by the oculomotor nerve, right? Typically, if we have a down and out pupil, that means that the trochlear nerve, which is controlling the superior oblique, is allowing that muscle to kind of pull down, and then unopposed lateral rectus, both of those will pull the eye down and out. So if we're thinking of 3, 4, and 6 for our cranial nerves and what they're controlling, 4, which is the trochlear, is going to control our superior oblique. 6, which is abducens, is going to control lateral rectus. And 3 is basically everything else. So this is superior rectus, medial rectus, inferior oblique, and inferior rectus. And don't forget the levator palpebrae superioris, right? So in this case, 3 also carries the parasympathetics that we have knocked out here. So that's why we have that down and out pupil. So in this case, this is going to be some sort of compression by a PCOM aneurysm. And a PCOM aneurysm is the most common issue when we have just a 3 knockout. So when we just have a cranial nerve knockout, it's going to be a PCOM aneurysm. The reason we know it's 3, obviously we have all these symptoms of this being affected, but also remember the superior oblique is going to pull the eye down. Lateral rectus will help pull it out, down and out, both of them together. You'll have the down and out pupil. All right. Okay. Let's move on to 19. Our second to last question for the night. We have a patient that presents with ptosis, meiosis, and anhidrosis on the right side of the face. Which pathway is interrupted? So, ptosis, meiosis, anhidrosis, we've talked about this earlier. This is Horner syndrome, right? When we lose all of our sympathetic nerves or our sympathetic innervation, we're going to have Horner syndrome. It's due to a couple different things. A Pancoast tumor, a tumor at the top of our lung, can push onto the sympathetic chain. So in this case, sympathetic chain is going to be where we have an issue, but we have no sympathetic innervation. You could also have issues elsewhere, but this is just the most common area for you to have an interruption to have a Horner syndrome. All right. Pancoast tumor, you could also have some sort of tumor that causes SVC syndrome, superior vena cava syndrome. And in that case, with superior vena cava syndrome, you'll have like flushing of the face, that kind of thing. You can also have Horner syndrome from things being knocked out. Okay. And then let's move on to our final question of the night. We have a 67-year-old man who suddenly develops left homonymous hemianopia with macular sparing. Which artery is most likely occluded? Well, remember earlier I said that there's a very specific stroke that'll have macular sparing because the macula has collateral supply from the MCA. And if you guys remember, left homonymous hemianopia means that that entire side of the brain is knocked out. This is the occipital lobe. When you have left homonymous hemianopia, the occipital lobe is knocked out. And what's going to be knocked out? It's going to be the PCA. because the PCA is providing blood flow to the occipital lobe, but the fact that we have macular sparing means that our MCA is providing that extra blood supply, so the macula isn't knocked out as well. So PCA stroke causing the contralateral homonymous hemianopia. So this would be a right-sided issue, and that'll cause the left homonymous hemianopia. And we are done. Any questions from anyone, or any comments, concerns, hatreds? No, I'm kidding. Ooh. Anyone got some aspirin for my back? No, I'm kidding. Oh, I'm not that old. Although I do get mail from AARP, so they are trying to give me some of these brochures to try to convince me to buy into their old people memberships, you know? So yeah. I know, too early for that. 19 from the neuro side, so the Horner syndrome. Oh, the sympathetic chain. So in this case, anytime we think of Horner syndrome, that means we don't have sympathetic innervation. Sympathetic chain, which typically is from T1 to L2, right? This is where our sympathetic chain comes off of the spinal cord, technically, in terms of our nerves. This sympathetic chain then needs to send nerves back up to the brain as well. And so that's where we, because anything sympathetically innervated has to come out of this sympathetic chain. So in this case, if we have a Pancoast tumor potentially, Pancoast tumor would block up the sympathetic chain and crush it. Or you could have some sort of stroke that'll block off the sympathetic innervation as well. So that's why some sort of sympathetic chain defect is what's causing this.